Good afternoon. My name is James Tulsky, and I am the chair of the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute and at Brigham and Women's Hospital in Boston. Together with Peggy McGuire, who is the president of the Cambia Health Foundation, I'm the co-chair of the National Academies Roundtable on Quality Care for People with Serious Illness. We'd like to start by welcoming everyone to this webinar. The roundtable, you can get more information at our website, and the link is on the slide, but was created a number of years ago to explore and highlight key themes related to serious illness care in the United States, and really following up on the National Academies report on care at end of life that was published in 2014. I would like to thank the roundtable sponsors and who are listed on this slide, without whom we would not be able to do this work. And these are the members of the roundtable. I'd also like to let you know that a recording of the webinar and the meeting materials will be available on the event webpage. Again, you can see the link here. And at the end of every session, there will be time for question and answers from webinar participants. And when you ask your questions, we ask that you use the Q&A box as opposed to chat. Finally, I would like to thank the planning committee that put together this remarkable series of webinars. This is now the third in a series of webinars on COVID and serious illness. And if you've had the opportunity to listen to the first two, they've been brilliant. And they are now also going to be on our website. You'll be able to peruse them if you haven't seen the other ones. And it's been the remarkable work of the people listed on the slide here, led by the co-chairs, Brent Bowman and Susan Wong, who have, as well as together with our remarkable National Academies staff of Lori Gregg, Caitlin Friedman, and Licia Wilkes, who have really been able to make this happen. So now what I would like to do is introduce Brent Bowman, who is one of the co-chairs of the Workshop Planning Committee.
Thank you, James, for that introduction. And I'd actually like to start by passing the baton to my co-chair, Susan Wong, to help us recall the themes from our first two webinars in this series.
Thank you so much, Brent. And thank you, James and Peggy, for your leadership on the roundtable. We are grateful for you both. And pleased to welcome everyone to the final webinar of our workshop. This program was developed to examine the impact of the COVID-19 pandemic on serious illness care, with an emphasis on health equity and shared learning to guide us into the future. Amy Kelly and others have defined serious illness as a health condition with a high mortality risk that also has a negative impact on function, quality of life, or caregiving. In the context of our agenda, serious illness may include acute coronavirus, long COVID, as well as advanced disease like cancer, dementia, and heart, lung, or kidney failure, in which diagnosis or treatment is impaired by the limited capacity of our hospitals during a global health crisis. In case you missed the earlier sessions, I am happy to provide a brief summary. Dr. Harvey Feinberg started us off in webinar 1 with lessons learned from previous health emergencies and how leadership and public trust help to coordinate a strategic national response. Dr. Gerard Carroll taught us to use good communication, advocacy, and self-care to navigate rapid change. Dr. Judy Salerno led a panel discussion with Brent Bowman on the critical value of palliative care for patients, families, and health systems. After a video montage of innovations across the country, Carla Davis spoke about their pop-up inpatient hospice facility. Dr. Claire Ancuda described their 24-hour patch line for palliative consults. Dr. Susan Cohen shared a model of pairing palliative care with ICU teams. And Chris Halsey talked of chaplaincy and virtual well-being support. Dr. Ebony Boulware described how baseline health disparities were magnified by the pandemic. and Lori Bishop and Karen Bullock hosted an exchange around what is needed to achieve health equity and sustainable transformation. Webinar 2 focused on the key areas that have been permanently altered by COVID, our serious illness workforce and telehealth. Dr. Rodney Tucker shared his experience as a palliative physician. Liz Fowler discussed strategies to support the hospice and home care workforce. Elaine Larson outlined opportunities to strengthen the nursing pipeline. And Dr. Shreya Kangovi explained the benefit of community health workers. We considered mental health, workplace safety, and the impact of racism on our workforce. Then we examined the rapid shift toward telehealth. Steve Clauser spoke about research efforts to understand the value of virtual care among people with serious illness. Dr. Jacob Strand addressed telehealth and palliative care. And Pat Justice shared the experience with virtual care in rural communities. Hayden Hiskamp conducted a conversation around barriers to good telehealth, as well as the benefits of increased access to specialty palliative care and connection with families. It has been a rich dialogue so far, and I look forward to the continued engagement. Bryn, I'll hand it back to you to introduce today's webinar.
Thanks, Susan, for that great recap of where we've come so far in this workshop. And in today's webinar, we're going to tackle two topics that are critically important to the care of patients with serious illness and that are complex, that certainly don't have easy answers. In our first session, we will focus on public health communication. In a public health emergency with very quickly evolving information, how do we do rapid translation of research, not just into clinical practice, but into our communications to the public? This session will be moderated by Dr. Pam Hines, Executive Director of the Department of Nursing Science, Professional Practice and Quality and Research Integrity Officer at the Children's National Hospital, and Professor of Pediatrics at the School of Medicine and Health Sciences at George Washington University. Dr. Hines and our speakers will help us evaluate what's been effective versus what may have been, upon reflection, harmful with respect to public health communications up until now in the pandemic. Our speakers will help us to derive lessons that can be applied to future crises or quickly evolving bodies of clinical knowledge. In our second session, the final session in this 3-webinar series, we will look back at the discussions from the entire workshop and attempt to synthesize a call to action for strengthening the care of people with serious illness and their caregivers, a call to action both for policymakers and for healthcare providers. And now I'm excited to move to our keynote remarks for session 1, delivered by Dr. Ashish Jha, Dean of the Brown University School of Public Health, and a public health communicator who has been a trusted source of information and analysis for so many of us during this pandemic.
My name is Ashish Jha, and I'm really pleased to be here this afternoon with all of you. So my hope in this part of the workshop, in my remarks, is really to talk about the importance of public communication in a health crisis, the pitfalls of public communication, and some of the challenges we have as scientists and as public health officials and public health academics in communicating effectively with the public, and then some ideas about how we might do this better. And then I hope that in the Q&A that follows, we're able to kind of delve into these issues a little bit more deeply. So let's begin by asking the most basic question of all, which is why do this at all? Why communicate with the public? Why is that so important? I mean, isn't the job of public health ultimately to get the science and evidence right and get the policies right? Well, certainly getting the science and evidence and policy right is central. But communicating with the public is always important, and particularly so in a health crisis. And this may seem obvious, but it's worth taking a minute or two to talk about it. Because in a health crisis, and obviously we'll talk about the COVID-19 pandemic, we ask people to do extraordinary things, right? We ask people to stop leaving their homes unless it's absolutely essential. We tell them to start working from home. We tell them to stop seeing friends and family who don't live with them. These are incredibly disruptive things. These are the things we asked people to do last March and April and May, and have at times asked them to do again when the infection numbers have gotten very, very bad. We've asked people to put on masks when they go outside, when they go into indoor spaces. Initially, we told them it wasn't necessary, but eventually we made the case that actually was really, really helpful, and we continue to ask people to do that. 2 years ago, that would have been an odd thing to ask people to do. Now that has become a routine ask. We've taught people about testing. More Americans have learned about quarantining and isolation in the last year and a half, 2 years than they had ever learned in their lifetimes. Again, there are extraordinary moments where we have asked people to fundamentally alter the way they live their lives, the way they see their loved ones, the way they engage with their work, the way they engage with school. This is hard stuff to ask people to do. And in general, under most circumstances, people will not say yes unless there is a compelling reason. And you can get the policies right. You can get governors and mayors and presidents to make the right policies. But in order for those policies to come true, you have to explain to people what's going on, what the underlying issues are, and how they should understand it, and how they should really learn to live with it. Now, that requires extraordinary public communication ability and training. And I would argue that most of us in public health, most of us in science, most physicians have not been trained in how to do that effectively. Now, 2 years ago, if we were all sitting together and talking about a health crisis and what we might do, I would have naively said, and in retrospect, it sounds extraordinarily naive, but I might have said that the most important thing that we could be doing, or the main job of public health in terms of scientific communication, is to first, in a novel disease, get the science right, get the data right, figure out the evidence, synthesize that evidence, right? And then explain it to the American people in a way that makes sense. And fundamentally, the belief was that facts, evidence, science, data will alter behavior. Now, that may sound extraordinarily naive at this moment, and I will argue that certainly that was a strongly held belief I had. And of course, there's still some truth to it, right? Facts do matter. Evidence does matter for people. It is not that it doesn't matter at all. It is that what we have learned is that in order to get people to act, in order for people to change what they do, it's not just about giving people facts. It's also about understanding and addressing things that they value, things that they find meaningful. And that really requires an understanding of a variety of things that we in public health and in science have largely not been trained in. And we can't just go up there on TV or in the newspapers or in other contexts, town halls, just regurgitate a bunch of data and evidence and say, that's the evidence, use it as you will. We have to understand the fears that people have. We have to understand the anxiety people feel. And we have to understand what is going to motivate people to do things that are going to be in their own best interest and their own best health. Now, you may say, well, there are people who've been studying those things for a long time. It's true. And behavioral scientists have been telling us that those are the ways that we move people. Most people in public health, most people in science communication have not learned those skills. And that, I think, really got us into a whole lot of trouble. Now, the pandemic, the COVID-19 pandemic, has become, therefore, I would argue, a breeding ground for misinformation and disinformation. It's worth taking a moment and thinking about the historical context. Pandemics have always been a breeding ground for misinformation. There have been anti-vaxxers as long as there have been inoculations and vaccines, going certainly back to the days of smallpox, where you had entire groups of people pushing back against inoculating against smallpox, saying somehow that inoculation was dangerous. You had, in the 1918 flu pandemic, you had the Anti-Mask League, people out there arguing against masks, making exactly the same nonsensical, bogus arguments then that they are making today about how masks cause their own infections and cause retention of carbon dioxide and all the stuff that you've seen trotted out. Now, why does this misinformation thrive in a pandemic? Why does it thrive in a pandemic? Why does it thrive in a crisis? And why particularly has it had such a big role in this one? And I think it's worth taking a minute to think about those things. It thrives at moments of uncertainty. It thrives when there is an information vacuum. When people are uncertain and people are tired and people are scared, they need information, they need knowledge, they need something to hang their hat on, something that they find meaningful, something that they can value. And misinformationists have gotten very, very good at identifying those moments and offering up things that feel right, that seem right, even if they are not. Now, what is made worse so that, by the way, is a truism throughout all of history, right? That's not a phenomenon of the COVID-19 pandemic or of the 21st century. What is a bit more of a phenomenon of the 21st century, and certainly we've seen this play out in this pandemic, is the information echo chambers we live in. We all live in information echo chambers. It is easy to say, and most Americans believe, that the other guy lives in an information echo chamber, that someone else is in an information echo chamber. And we, of course, are all getting perfectly good information. That is a widely held belief, and it is largely wrong. That the information architecture of kind of America today, the world today, creates these self-perpetuating, self-enforcing information echo chambers where one bad idea can take hold, get amplified by multiple actors, and at some point, sooner rather than later, starts becoming gospel truth. That's how misinformation thrives. A second issue, which is disinformation, which is really about information from bad actors who are purposefully creating bad information to create confusion. That is also a relatively new phenomenon. It is true that at war times we've seen propaganda, but the kind of disinformation we see now, certainly around the pandemic, but also around our democracy, around climate change, disinformation often created by state actors. Russia has been a major source of this kind of disinformation, but also disinformation purveyors here in the United States. These are people who have essentially weaponized misinformation. They are polluters. They are putting toxic waste into the information ecosystem. They usually do it for political reasons. Sometimes they do it for profit. And there's only one way to deal with that crowd, which is really to go after them on the platforms that they use. And so this isn't a responsibility of Facebook and Twitter and Google to deplatform these folks, because there is no engaging them. This is asymmetric warfare and requires a very specific response. But I want to shift back to things that we can do as scientists and as public health officials. So we're not going to be able to counter all the disinformation out there. That, again, we're going to need help. But there are things we can do to be more effective in the information ecosystem we find ourselves in. And in order to do that, first, I think we should better understand where we struggle. And when I think about science communication, and I think about the way I was trained as a scientist when I wrote papers and they would come out in a journal, how I was trained to talk about it, even how we write papers where near the end of the paper, we take a whole section to talk about limitations and all the ways in which our papers are not definitive and all the uncertainty they still leave on the table. This is how science works. And in general, it's a really, really good thing for the scientific process. It does not work well in public communication. We really struggle to convey uncertainty effectively. We, of course, in science live in uncertainty. So we play it up when we give talks and when we speak to each other. We think about all the exceptions that might make our findings null, or at least may not fully apply. And we are uncomfortable with judgment calls and experience as experts. That's not what we're called for when we're discussing papers and science and evidence. We like to lay out all of the limitations of that work. Well, that can be helpful and is really, really good as a tool for communicating among scientists. It can get us into a lot of trouble when we're communicating more broadly to the public during a health crisis, right? So let's talk a little bit about that and what happens. One of the things that's really important that we have not done an adequate job of is communicating to the American people that science is a process. It's not a destiny, it's not an answer, it's a process. And when we say follow the science, we don't mean follow a finding that is going to be true forever. It is follow the process and see where that process leads you. We have to do a better job of communicating the process. And I'm going to come back to this a little bit more just as I wrap up. We have to explain to people that there are things we know at a given moment and that we will learn more over time, without overly emphasizing all of the uncertainties and all of the unknowns, but without overstating it either. And this is a very difficult situation. And my general approach on this has been to recommend that we talk about what we do know and provide judgment about the areas where there is a lot more uncertainty. Explain the uncertainty, don't hide it, but at the same time, provide judgment. And I'll give a specific example. In the early days of the data, when the data came out about vaccines, the mRNA vaccines, Moderna and Pfizer, one of the big questions that was on people's minds was, would these vaccines actually slow down or reduce transmission? Most experts came out and said, we have no idea, because the studies had not definitively shown that vaccines reduce transmission. And most Americans heard that, not as we don't know, but that they don't. And for months, the broad consensus in the minds of the American people was vaccines don't slow down transmission, which of course was not true. And the correct answer would have been, a more effective answer would have been, while we do not know for sure whether vaccines reduce transmission, they likely do, because most vaccines do. And if you prevent infections, you're most likely to reduce transmission as well. But we don't know that for sure. I think there is a way to communicate about this stuff that gives people a judgment about what is likely to be the case without overstating what you do and don't know. Through that process, I think we can actually begin to train people to understand the scientific process. I think that is actually absolutely critical, and that is something we have not done enough of. Let me make a couple more points and then I am going to wrap up. So the one part of public communication is about talking about uncertainty in ways that are more helpful and less nihilistic, right? Second is, as I said, explaining the process by which science happens. Third, which I think is really important, but makes a lot of people in the science world uncomfortable, is connecting based on personal experience. So one of the more effective tools that I have seen used, and I have tried to use personally myself, is whenever there are important questions, what should we do over Thanksgiving? Should elderly people get the booster? Should kids get vaccinated? I often try to begin with my own personal decision on these things and then explain why based on the evidence. That's an uncomfortable area for a lot of scientists who want to take one step away and say, let me just tell you the science of the data. You should talk about the science of the data. But by connecting it then also to the personal experience, you help people feel much more in touch with that data and much more confidence in that data, that this is not just generic advice, but it is advice you are taking yourself. Key part of that is explaining what in the evidence has really moved the decision making, and still explaining the uncertainty of what we don't know. And then here's the last point that I think is critical. When we talk about uncertainty, explain what will allow that uncertainty to be lifted. That what is the set of evidence and data that we are waiting for that will help us understand? People often ask these days, will we need another booster 6 or 12 months down the road? And the short answer is we don't know right now, because we haven't had enough experience. But there are studies ongoing tracking people with boosters to look for waning immunity. And even though we might suspect that people will have a reasonably robust response for an extended period of time, we don't know for sure. And those studies will tell us in 3 months, 6 months, 12 months, give people a sense of when that uncertainty gets lifted. It also, I think, provides both accurate information and helps people have a framework for understanding what's going on. It also makes them far less susceptible to misinformation when someone shows up and says, I know the answer today. They know in their minds that that answer cannot be determined today. We need more data on that. So let me just finish off here by saying a couple things. Public communication, I think, is absolutely essential in any moment of public health, but particularly in a health crisis. It is central to combating both misinformation and disinformation, both of which thrive in information vacuums. We haven't trained our public health professionals, our scientists, to communicate with the public in a way that is meaningful and effective to them. We're good at communicating to each other. We're good at using shorthand as a way to explain technical and complicated ideas to each other. We're good at explaining all the ways in which any single study is inadequate, and all the ways in which any set of data hasn't given you the full answer. I think that all makes sense within the scientific community. But when we get outside of the scientific community, when we begin to engage with the public, it is absolutely critical for people to help Americans understand the scientific process, communicate both uncertainty and certainty, communicate judgment, personalize it whenever that feels appropriate, so people know that this is not generic advice, but this is advice you would take yourself, and really build the trust and confidence that people need to fundamentally change their behaviors, because that's what we're asking people to do. We're asking people to do things they would never do before under normal circumstances. And that fundamentally requires trust. So thank you so much for letting me kick off this afternoon. I think this is, as I said, an extraordinarily important event. I'm so pleased and honored to be a part of this. The National Academies workshops are a really important way that we advance science and evidence and data, those things that we still believe in, at the heart of making the human welfare better. These workshops are such an important part of that, and it's an honor to be a part of it. Thank you so much.
Dr. Jha, I thank you. Every time I have the privilege of hearing you speak, I treasure your words. They're very straight, they're very direct. You make strong evidence to support them, and I'm very grateful for that. Your words are memorable, they linger. I'd especially like to raise the point that you offered about teaching the public about the scientific process. And as part of that, to make it personal, to talk about a personal decision, a personal experience. Would you share with us your thoughts about, in that context of teaching the public about the scientific process, when you find that on the personal level, perhaps you regret a decision or might even call it an error? How might you handle that in teaching the public about science?
Well, thank you both for this terrific event and for that question. I think there are a couple of ways that I might interpret your question, and let me try to actually answer both of them. One is, there are times when I've given advice and it's turned out wrong because the evidence changed. And that's a very specific kind of way of explaining it to people. So for instance, if we were here last April and you had asked me whether we would need boosters, I would say, based on all the evidence and data we've seen, I don't think people are going to need boosters. Because based on all the evidence and data I had seen at the time. And when that changed, I think acknowledging that evidence had changed and therefore the recommendation was changing, and reminding people that that's actually how you want your physician to practice medicine, that when new evidence comes out, that's what the physician does. That's one way of explaining to people, and actually just very much acknowledging that you had made a different recommendation, not hiding behind the fact that the recommendations changed. The second way to think about your question is, there are times when I just honestly get this stuff wrong, right? There's a barrage of information, and I have found that people generally don't penalize you for getting stuff wrong. I think they penalize you if you aren't willing to own up to it. And so whether it's on social media, on Twitter, or on TV, I've gotten certain facts wrong. I remember once talking about how well certain vaccines were holding up against a specific variant, and it was actually a different variant than I thought the studies had shown. It's about openness, acknowledgement, and sort of what we would do if we had submitted a scientific paper and found an error. The first thing you do is you call the journal and say, hey, we got this one wrong. I want to submit an update. And that, I think, builds long-term credibility. People worry excessively that somehow if you make a mistake, people will trust you less. I haven't experienced that. My personal experience is, if you make a mistake, which we all do, if you own up to it, people tend to trust you a bit more, actually.
I find your words really giving us the elements of intervention. You spoke about know your audience's values, know their motives, know what worries them, help them to think of this as what could be in their best interest. So knowing that those might be core elements of any communication intervention, I'd like to link that to the two groups that you really have powerfully identified: those who are involved with misinformation, those who are involved in disinformation. Would your approach to those two audiences be different with those core elements of a communication intervention?
It's a good question. I mean, the part of it is you have to understand, in my mind, what motivates people to both create and spread misinformation and disinformation, and they are different. As I mentioned, there's a disinformation I sort of think of as like well-planned, organized, often by foreign actors. That requires a very specific set of interventions that probably go beyond what I am able to do, right? And that's why we talk about that stuff Facebook, Twitter, YouTube has to manage. the misinformation that's more commonly spread and shared around. The two things in my mind, there are two groups within that. One is a group of people who are actually trying they have an ulterior motive. What do I mean? They often have something to sell. They often have, hey, don't use these vaccines, but I've got a little tonic that you can buy from me that'll cure your COVID. Understanding that for those people, there's a very kind of motivated set of reasons why they have the misinformation. But then there is a larger group of people who believe misinformation based on what they hear. And there, I think, to your question, Pamela, I think one of the key issues in my mind is understanding why certain types of misinformation sticks with certain people. And here, I will tell you that there's another mistake that we make. I didn't mention this in my talk, but we often tie certain set of beliefs to identity. And I'll give you a specific example. There have been a whole lot of public health people who've been saying, oh, the vaccine hesitancy is among Trump supporters and on President Trump's supporters. Mm-hmm. I think that is an extremely unhelpful way to look at the world. And I'll tell you why. Because if you are someone who's on the fence on getting a vaccine, and then you hear from public health people that Trump supporters are vaccine hesitant, then you think, well, I voted for President Trump. Maybe I don't want to be getting the vaccine. Mm-hmm. And what you've done is taken a standard public health measure that we all need to be kind of involved in and tied it to political identity. And that is never, ever helpful, because then moving people away from that position gets much, much harder. So all the folks out there talking about how vaccine, and first of all, it doesn't even necessarily turn out to be true, but to the extent that there is some data that there is an association, it's been very harmful. So understanding why people believe what they believe, understanding the identity that is linked to that misinformation, and trying to break political identity from public health messages is a really important thing that we all got to work on.
I very much appreciate that. And I think you've emphasized there can't be just one voice. There can't just be one scientist coming forward, one source of information. It really has to be more of a movement with being available, filling the space, the silence, the confusion. What about your comment about timing? Could you say more about timing of interventions, whether it's to different audiences or just timing in general?
Timing of kind of communication interventions, is that what you mean?
Yes, please.
Yeah. Well, let me answer that in two ways. So one is, I mean, this exact moment we're in. Over the weekend, many people became aware of this new variant that's been first identified in South Africa, Omicron. And there is a period of time when the uncertainty is high, anxiety is high, but unfortunately, information levels are very low. We just don't know that much about this variant. And people stepping up to fill that void with the best information we have is critical. If all the sort of scientists said, look, we don't know anything, we're not going to talk about it until we know more, call us back in 2 weeks, that would not work for two reasons. People feel anxious now. And if you don't fill the gap, other people will. Mm-hmm. There will be plenty of people with far less knowledge who will be happy to step in and spread misinformation. Mm-hmm. And when anxiety is high, people are grappling for information, misinformation sticks. So getting timing right is very, very important. And that means being willing to speak up when we don't know a lot. The second part, sort of related to your question that I want to emphasize, is that it is a movement. And that everybody, and I think physicians, scientists, public health people, most people think, well, I don't want to be on national television, or I don't want to go do this. We all have a role to play. And right, there are lots and lots of local media. There are local groups and town halls and lots of ways of communicating. And that all builds a movement for good information. The best way to counter misinformation is to flood the zone with good information. And what I would say to everybody who's listening is ask yourself, like in a crisis like this, where information is at the heart of the crisis we are in, how do you play a role in spreading good information? How do you play a role in bolstering good information? That's a critical job that we all have.
I very much appreciate your words about that and the professional courage to step into what could become an information void. You indicated that with disinformation, really we need systems to go after that, Facebook, Twitter. But I happen to know that you've had the professional courage to step in with different situations and to speak. Could you address that now and about what prompted you to do that and the strategies that you used because you were in a difficult circumstance several times?
Yeah. And sometimes without even knowing that I was stepping into a truly misinformation event. But I will say this, that in this pandemic, there have been very, very well orchestrated misinformation and disinformation events. And they require, and by the way, I have learned how to manage this. Like, this is not stuff I ever thought about 2 years ago. And so I'll give you a very specific example of a part that we got, I think, not quite right, and then how we addressed it a few weeks later. So in late November of last year, so just actually about a year ago, Senator Ron Johnson of Wisconsin held a hearing in the Senate on hydroxychloroquine. This is November of 2020, and all of us thought, hydroxychloroquine, and we're in November? Like, I thought this was all settled. But sure enough, he had 3 physicians who all were major proponents of hydroxychloroquine. And the Democrats asked me to come and give the kind of the evidence on hydroxychloroquine and oral therapies, and I was happy to do it. And I showed up, and what I learned was this was it was a misinformation super spreading event. It was designed and orchestrated by members of the Senator Johnson staff with a lot of bloggers who basically use that event to try to kind of get hydroxychloroquine back on people's agenda. And that's because this was mid-November, vaccines were about to start coming online, and their agenda was to counter vaccines and say, actually, we don't need vaccines, we have really effective oral therapies. It turned into a bit of a disaster because I spoke up obviously quite loudly about the evidence. I talked about the professional societies, IDSA, and all the others that have basically said don't use hydroxychloroquine. I talked about FDA, NIH, kind of basically pointing to American medicine and the scientific process as why we can reject most of the bad science out there. And they very much sort of turned this against me, and it became much more about, you're part of the establishment and you're not. Anyway, it was fine. The event itself was fine. What was really interesting that followed, I don't know, interesting, but sort of one of the few times I had wondered whether I was doing the right thing, was essentially several weeks of just barrage of personal attacks, death threats, a concerted target of calling my office, calling Brown University, calling the president and provost of the university on a regular basis, trying to get me fired. Thankfully, they didn't. But it was harassment, and it was harassment with the goal of raising the cost of engaging with them and pushing back against them. So I felt like that was actually not our finest moment. We should have probably not. And so what happened was, when Ron Johnson created a second hearing around vaccines and got a bunch of anti-vaxxers to come, the decision that we made with the Democrats in the Senate was we wouldn't have any Democrats show up and we wouldn't have a witness at all. And that, in fact, the way to counter disinformation is to not give it oxygen. And so none of us showed up, and it basically got no coverage and not much came out of it. These are lessons that we're learning.
Yeah.
But I think part of it for me has been being out there trying to advocate for what I think is the scientific process is really important. But, again, the threats I face, I think, have been modest compared to what other people, Peter Hotez has faced, a barrage of them. What Tony Fauci has been going through over the last year is beyond kind of believable in terms of the attack. So we're in a very unusual moment where when people don't want to attack the science or the data, they start attacking the scientists.
I appreciate your courage to step into those situations and when to not step in. I appreciate the wisdom that you have just shared. We do have a question for you in the Q&A, and I welcome anyone else to also submit a question to the Q&A. And this question is, Dr. Jha, do you feel that you have had particular influence in the state of Rhode Island or Brown University because of being known, or is there a difference in the receptiveness to your information there as compared to elsewhere?
Yeah, it's a great question. Thank you. Different, I would say different between Brown University and the state of Rhode Island. At Brown University, absolutely. I feel like, look, I am, as an expert, and this is actually really an important kind of broader point that I think we all need to understand. I bring I can bring evidence, I can help people understand it, I can give weight to it and judgment around it, but I don't make policies. But within Brown, I feel like most of the times I give advice and guidance, it gets followed because the university is run by academic leaders who want to do that, and their constituencies, by the way, the people they're accountable to, are also academics, and so it's a very different kind of environment. But when I think about Rhode Island, my influence in Rhode Island is much the way it is in many other states where I have relationships with governors. So I have a good relationship with Governor McKee, who is the current governor. I had a good one with Governor Raimondo before. There are probably about a half a dozen governors I speak to on an ongoing basis when they feel like my advice is useful. And the relationship there is very, very different. And this is actually, as I said, this is important to understand. I will give advice, and I would say with some frequency they will listen, but with a large frequency they don't follow exactly what I say. That's not necessarily a problem in my mind, because I am not accountable. No one elected me. My job is not to do all the weighting of all the different constituents and political forces. My job is to give the best scientific evidence on what works and what doesn't. And governors who are accountable have to weigh that compared to a lot of other things. So I never take that stuff personally. There have been plenty of times when I have given advice very, very strongly, and the governor has looked at me through a Zoom call and said, "Thank you very much, we're not going to do that." It's okay. It's okay. It's not personal. And as long as they're willing to keep calling back and looking out for advice, I'm happy to keep giving it. But it's a reminder that public health is really important, but it's not the only important thing in people's lives. And it is the job of political leaders, good political leaders, to weigh and balance these things.
I very much appreciate your wisdom, and I can't thank you enough for your presence today, for the sharing of your experiences, and for stepping into what I know have been vacuums. I deeply appreciate you, your voice, your words, and your style. So thank you. I know you're going to stay with us while we move into a panel moderation later. I want to thank you for that too. Thank you, Dr. Jha.
Thank you.
And now I'd like to introduce a representative for what we think is really important with communication, something that Dr. Jha mentioned already, but we're now going to focus on completely, and that is the personal experience, the lived experience, the knowledge that can come from that, and the opportunity to influence using the lived experience. I'd like to introduce to you Dr. Daniela Lamas, who is going to be the person describing to us the lived experience, the personal knowledge. Dr. Lamas is a physician in internal medicine for pulmonary and critical care, and she is at the Brigham and Women's Hospital, and she is on faculty in Harvard Medical School. Dr. Lamas, I welcome you to this panel presentation. Please go right ahead.
Unmute. It is strange that after all this time, I still sometimes struggle with the mechanism of Zoom. So unmuted and video on. And thank you so much for the opportunity to talk. So just to set the stage, and talk for about 10 minutes. I'm going to give you an overview of sort of what it was like in the hospital during coronavirus, which is something that I've written about and thought a lot about, and then just use that to talk sort of broadly about my thoughts and our thoughts right now in the hospital, of sort of what we have learned from taking care of seriously ill patients during this pandemic and what we can do better. So first, let me just take you back in time a bit. It's April of 2020. You're in the hospital. You have your brown bag of personal protective equipment, back then with a mask that you might have used for days on end. These are images that we have all seen. They grow almost tired by now, but just imagine you're there and it feels new. You walk into the unit, it's been transformed. The doors to each patient room are closed. A ventilator monitor sits outside each room, and it strikes you, struck me back then at least, to look somewhat like a disembodied head. IV poles crowd the hallways. No one wants to enter the rooms. Some of the doors have a small collage outside, like a get to know me poster with the patient's name and photograph of happier times and facts that feel entirely incongruous now. My favorite food, my favorite season. It's something, but it's a poor approximation of how it used to be. Families at the bedside all day, eager to tell you a story about this person you're taking care of. Now, if you peer into the rooms, they're mostly empty, save for the patient lying on their stomach, face down or turned to the side. There are patients whose faces you've never seen. So you're walking down the hall and a nurse pounds on one of the doors. She's trying to tell you something, but you can't hear her through her mask, through the door. You've never realized before how much you rely on reading lips. You're trying to decode what she needs when you get pulled away because there's a family member on the phone. It's the wife for the man down the hall. He took a turn for the worse last night, and we've decided that she can come in, but she's not sure she can tolerate it. After all, it's been weeks since she's seen her husband, and you've told her each day that you're worried about him, but it's sort of become this new kind of stable for her, these words on the phone that mean very little. And you think you both know that that false picture of stability will be destroyed if she enters the hospital. She tells you she's been reading studies and she wants to figure out if you can get her husband convalescent plasma. You take out your patient list and write palliative care next to his name. They're going to come round with you later and they can help her navigate what is to come when your pager alarms. It's the ER and admission. You finish the call with the patient's wife, promising to call her later, scan the new admission as you talk. It's actually an overdose this time, not COVID, but another overdose. A 35-year-old died of alcoholic liver disease down the hall a few days ago. This overdose is COVID negative, so he's not yours. He'll go to the other regular ICU. A reminder that all other sickness continues too. You pause, you take as deep a breath as you can in your mask. It's nearly 7:30 in the morning, time to start rounds. So life in the early days of the pandemic moved so quickly that there was barely time for anything more than practical questions. When to intubate? Should we use high flow oxygen, even though it might put us at risk? Was it irresponsible or humane to try to sneak in that extra family member overnight? But now, looking back, different questions begin to emerge. What did we do well? Where did we stumble? And as we all move towards some sort of new normal and try and grasp at post-traumatic growth to make meaning of the past 18 months, what lessons can we take with us of how to care for seriously ill patients? I'm going to walk you through some of my thoughts. They're by no means the answers and will continue to evolve over time. But this is where we are now in November of 2020. 2021, that is. Clearly, time is fuzzy. So when I think back to the start of the pandemic, I always think about the ICU before. And when I do, I see the families, observing ICU procedures, sometimes even present at resuscitation attempts. Before COVID, we increasingly had come to recognize in the hospital that families were not just visitors, they were essential members of the care team. And then one day they were gone. And they have still not come back in the same way. We still do not regularly have family members with us on rounds in the intensive care unit. There are visiting hours that are circumscribed. So what happened when the families left the hospital? At first, I was so aware of their absence. I walked through the family meeting room and took in the silence. But then over time, as the threat from the virus decreased, little changed. We didn't really bring the family members back that quickly, not en masse. And I had to wonder, why did we not move more quickly? What did their absence teach us? What were we missing? The studies are just beginning to come out, but I can tell you this, without families in the hospital, it's quiet. In the ICU, we struggle to know our patients as anything more than a list of diagnoses. Subtle but potentially meaningful clinical changes are also missed, I'm sure. I can actually think of a few examples, particularly in the long-term acute care hospital where I also work. A stroke that would have been caught earlier had a patient's husband been at the bedside. And for the families, can the trust that is built over minutes and hours and days at the bedside somehow be forged in a phone call? The lesson that we draw from all of this and what happens next in terms of families in the hospital, I think remains to be seen. Looking at my own hospital, I find myself worried that we didn't bring people back more quickly, particularly in the ICU. And I think that there's a real inflection point here in terms of our acknowledging that family members are not just visitors for the seriously ill in the hospital, but they are an essential aspect of the care that we deliver. And my hope moving forward is that all of this shift does not turn back the clock decades on acknowledging and recognizing and acting upon how important families are in the care of the seriously ill. And knowing what happens next, knowing how we take this and how we move forward, that's still in our control. And my hope is that our conclusion will be that families are essential, that something was lost, that we need to bring them back and make them a part of care. In thinking about the role of families, we often struggled with patients who didn't have clear decision makers and whose families weren't in agreement about who's going to make treatment decisions. So of course, many of these patients in COVID were previously healthy men and women who had never really thought of illness, of a time that they would be unable to make their own decisions. But they're in the hospital overnight trying to determine who to call and who a patient would trust to speak on their behalf in a context no one could have imagined, reaffirms that deciding on a decision maker is a key step that everyone should take. That's something that we can take away from this. In these conversations we had, often overnight, we had to ask healthcare proxies to trust us. We had to do so even though they were not at the bedside, even though they couldn't see our face or read our body language, and even though, particularly at the outset, we could barely trust ourselves. Navigating uncertainty and gaining trust despite uncertainty became key in this pandemic. There was so much fear of the virus, of course, but also fear on the part of the families of interventions being withheld, fear of scarcity of equipment, fear that we were giving inaccurate information. And as for us, the physicians and nurses, the fear that we weren't giving the best possible care. There was a time early on when I believed that we didn't know what the best care should be. Was it convalescent plasma, as my patient's wife was asking about? Was it intubation? But in focusing on these questions about new interventions, about medications, to the exclusion of all else, I think we did something where we set aside what we did know. We do know the components of high quality critical care. We know about waking patients up every day, minimizing sedation, meticulously monitoring labs and ventilator settings. But in the early months of the pandemic, we let fear take hold and set our protocols aside. That's entirely understandable, but it was also an error. And when faced with serious illness and with fear and misinformation, we must make sure that no matter what else is going on, we don't lose sight of life-saving fundamentals that we do know. For those who survived the virus, COVID taught us one final lesson, and that is that surviving serious illness is not the same as recovering. In critical care, for decades, the research and focus has been on mortality, alive or dead at 30 days, 60 days, 90 days. But what about the quality of the lives that were saved? This has only more recently become an issue of focus in critical care, leading to new diagnoses like post-intensive care syndrome and an understanding that there is a growing population of people with long-term dependence on the ventilator or other life support technologies. For a long time, this population was not in the public eye, but now, with the population of coronavirus survivors, both ICU survivors and then long COVID, there's a growing public understanding that mortality is not the only outcome that matters. And those of us in the intensive care unit must shift our conversations to take that into account. And the broader system must ensure that there are ongoing conversations through the entire trajectory of care for those who do press forward with aggressive interventions. These things do not end when somebody leaves an ICU doors. The pandemic tested our ability to care for seriously ill patients like no other public health crisis in our lifetimes. It showed us devastating truths about the fault lines in our country's belief in science and medicine, showed us that fact can be politicized, but that wasn't its only impact. It also broke down the divide between our patients and ourselves, forcing us to realize that anyone at any time could become seriously ill, and forcing us to see the extent to which we are all truly interconnected. And as we now have some space to reflect, it's time to take the lessons that this taught us and to use them to make care better. I think it's the only way forward. So thank you for the opportunity to give those remarks, and happy to talk more during the panel.
I am so grateful for your words, absolutely capturing the real importance of the lived experience being brought forward with other forms of evidence. I thank you, Dr. Lamas, and I'll see you in a few moments with the panel. Now, I'd like very much to bring to you two speakers who are going to address what we consider to be major populations affected by the pandemic, major populations that need our abilities to communicate. First, I'd like to introduce a colleague, Dr. Roberta Dibiase. Dr. Dibiase is the chief of the Division of Pediatric Infectious Diseases here at Children's National Hospital and is a professor within our Children's National Research Institute and also a professor of pediatrics, microbiology, immunology, and tropical medicine within the George Washington University School of Medicine and Health Sciences. Dr. Dibiase is going to tackle for us the myths that can cause harm in the world of children affected by the pandemic. She will be followed by Dr. Monica Webb-Hooper, who is the Deputy Director at the National Institute on Minority Health and Health Disparities. And Dr. Hooper is going to provide to us an overview of the impact on communities of color and disparities here in our country secondary to the COVID-19 pandemic. She will also present to us background information on a very important NIH initiative called SEAL Project. Dr. Dibiase, it is our pleasure to welcome you.
Thank you so much for the invitation. This is a wonderful panel, and it's great to hear all these perspectives. So in my 10 minutes, I want to give you a flavor of what we've experienced caring for pediatric patients and families that really touch on many of these issues we've already talked about. Next slide. So, you know, at the beginning of this, going back again to March and April of 2020, the initial reports were from China and even from the West Coast, when those first cases started hitting the US, were that children really were not affected. Not only were they not severely affected, but probably not even infected. And it was thought that less than 2% of infections were in children. And we were in very close contact because the pediatric ICU infectious disease world is very close knit. And we asked our colleagues, are you seeing kids pouring in? And the answer was no. And there really were very few admissions and only a handful of critically ill children. However, when this hit the East Coast, and there had been some time for this now to go through Europe, and then the strain that came to us here on the East Coast, we had a markedly different experience. And we started seeing significant number of infections, hospitalizations, and critically ill children. And then the emergence of this inflammatory disorder that you've all heard about now. Next slide. So right away, the American Academy of Pediatrics and the Children's Hospital Association, which takes over 40 hospitals that care for children exclusively, started compiling data from all the states. And this is now updated every couple of weeks. And as of a couple of weeks ago, there have now been almost 7 million lab confirmed cases, and certainly many more cases that are not lab tested. Children are 17% of all cases. And in the last few weeks, since they are a larger majority of the unvaccinated population, not because they can't be, not because they want to be, but because it's not yet approved in all age groups, they are now over a quarter of all the cases that are occurring. And for the 15th week in a row, we've had over 100,000 pediatric cases per week. The good news is that children represent only up to about 4% of all the hospitalizations. However, this is a very good example of communicating to the public. On the one hand, we need to make sure they don't panic that their child is going to be hospitalized or critically ill to the same extent that an elderly individual is. But it's also the wrong message to tell them their child can't be infected, or that they could indeed be one of the many tens of thousands of children who are critically ill or hospitalized. Next slide. And we've struggled with this throughout the pandemic. Here at Children's, we've now seen over 4,000 children who are symptomatic that have come to our doors. We've had over 800 that have required hospitalization. And in fact, a third of them have been critically ill, whether in our pediatric intensive care unit or our neonatal intensive care unit. And just as we got our feet under the ground on how to care for these pediatric patients, we have the new disease emerge that is unique to children, multi-system inflammatory disease, which seems to lag circulation of COVID in a community by 4 to 6 weeks. And 2/3 of our 200 children here at Children's that we've taken care of have needed major life support for this disease. Next slide. So we right away, when we saw that our experience on the East Coast was different than what had emerged on the West Coast, we knew right away we needed to educate not only the public so that they were looking for these signs of severe illness in their children, but also to let hospitals know, get ready, because you are going to have an influx of pediatric patients, and it's a specific area of care that needs to be organized in advance in your hospital. And as we've now seen over this 18-month period, this comes in waves in different parts of the country, and that allows us to share our knowledge with different parts of the country. As it happens to us, we can then pass it on to the next person so that they're not starting from ground zero. So this was one of our first publications on our first 200 patients. And it was really one of the first reports that said, yes, there is severe disease in children and young adults. We pointed out a variety of things that we don't have time to talk about, but that our youngest children under a year of age and our oldest over 15 were the most likely to be hospitalized, and that our children over 15 were the most likely to be critically ill. Next slide. We also were the first center to report and confirm the racial, ethnic, and socioeconomic disparities that were seen in adults, that they actually occur in children as well. And this was a very important paper in pediatrics that came out in pre-publication and finally in October of 2020 that shows you on the graph here to the right that our Black and Hispanic patients were 4 to 6-fold more likely to get infected. And in fact, even if we took out race and ethnicity and just looked at median family income, which of course is a marker for access to care, other markers of access to healthcare at all, our individuals in our lower quartiles were at marked increased risk for infection and severe disease. And this is all pediatric data based on an ambulatory pediatric testing and care center. Next slide. So then multi-system inflammatory disease came forth. And I have to tell you, I remember the day that these first reports came out of the United Kingdom. All of us were on the phone and on conferences 24/7 to decide, is this really a new disease, or is this just now something that we already took care of called Kawasaki disease that was more severe? And we were all having these meetings, had not yet hit the United States, but within 24 hours of those conferences, the whole East Coast, we all got cases that were nearly identical to what our UK colleagues were telling us about. And we're so thankful to them for raising this, awareness, because we were able to start recognizing these cases and optimizing the care of the children, which has dramatically reduced the number of deaths from this really devastating disease. We just recently published a compendium of looking at not only the epidemiologic and socioeconomic factors in these children, but also defining different ways that they can present. It's not all, they don't all look the same. We've looked at biomarkers, we've looked at viral sequencing, and all of this data that we're trying to share has really elevated how we can take care of these children. So as of today, we've had over 5,500 cases in the United States and 50 deaths, most of which occurred earlier on before the recognition was as readily available as it is now. And again, even more overrepresentation of Black and Latino populations compared to our primary COVID disease. So this cohort we've established and take care of is really an important cohort that we're now using to follow children long-term. Next slide. And this is really key. I think the CDC is a master at trying to figure out how to convey very complicated concepts to the public so that they get the right balance of how severe something can be, but not raising panic. So this is an example of an infomatic that was put together by CDC that can be put up in offices. We have it up in the hospital. We have it in practices so that families cannot worry so much about the immunologic mechanisms of MIS-C, but to know if they see persistent symptoms of these symptoms, that they really should worry a little and mention it to someone, bring that child to care, because these kids can rapidly deteriorate. Next slide. So what about vaccination? All the things we talk about with vaccination and misinformation are amplified when you're talking about vaccinating your child. And we know this from many other vaccines. Adults and parents appropriately have many questions about safety of vaccines and the necessity of vaccines in their children. So I'm going to just talk a little bit here about the 5 to 11-year age group, because we really have to work very hard to communicate to people how important it is to vaccinate this age group. On the one hand, we're telling them there's only a 4% chance your child's going to be hospitalized, and there's a very low chance that your child's going to die. And then they're hearing, on the other hand, that their child can get vaccine-associated myocarditis. So why would I put my child at risk of that? Well, we have to give them facts. So in fact, in our 5 to 11-year-old age group, there have been almost 10,000 children hospitalized in this age group, and 100 deaths of kids in this age group. So it is a real risk, even though the 4% is a low number. When we look at the whole amount of infections that occur in this age group, it is a realistic risk that there could be a significant number of hospitalizations or deaths if these children are not vaccinated. And then we need to share with them that over 2,000 children were studied, that many of the major children's hospitals were part of this, including ours, that there's 91% efficacy for these vaccines, and that we're using a fraction of the dose that was even used in the adults and getting really good efficacy. So these are all really important talking points that we try to do in our community and specifically on a one-on-one basis when friends approach us. But if you look below it at the percentage of people receiving full vaccination or even one dose of vaccination by age, it's a success story for our 75 plus patients. Look at this, 83% fully vaccinated, 97% with a dose. But as we come down in age, we have a long way to go with our pediatric population. Thankfully, our 18 to 24-year-olds, we're up in the 60 and 70% range. Even our 12 to 17-year-olds who had approval in May, we're in the 50 to 60%. But this new group that is just recently approved, we have less than 20% even with one dose, and we need to work on this. Next slide. What about long COVID? This is my last point. You know, we know that this occurs now. This is a really nice visual slide that was put out in Nature of Medicine that just shows you the whole host of things that adults and children with long COVID can experience far after their virus has cleared, as shown in these purple and green lines. So, you know, this is months out from their recovery. They have fatigue and quality of life issues. They have pulmonary issues with persistent cough and even persistent oxygen requirement. They have cognitive disturbance, headaches. They can have chest pain. They can have clotting disorders, a whole variety of things that are just being cataloged. Next slide. And what we really want to know, though, is this the same in children or is it different? So we have embarked on a large study of 2,000 children along with the National Institutes of Allergy and Infectious Disease, where we will try to look at this very carefully over 3 years, specifically in patients that are under 21 years of age. I put a couple of links here. If you have people that are interested, they can just click on those links and one of our study team members will contact them. Next slide. And what we're aiming to do is to recruit 1,000 recovered pediatric COVID and MIS-C patients, as well as 1,000 healthy contacts. And we want to capture the whole spectrum, those that are symptomatic, asymptomatic, hospitalized or not, critically ill or not, to really see who is it that gets long COVID in pediatrics and how often does it really happen? And we're doing a very extensive evaluation of these patients, including pulmonary, cardiac, neurodevelopmental assessments, which is really unique to pediatrics. These kids are trying to develop on top of getting over a major illness, and all the quality of life and mental health assessments that are necessary. We'll also build a biorepository and be answering a lot of important basic science research questions in this pediatric age group. Next slide. So, you know, these are all direct effects of COVID and MIS-C, but there are so many secondary challenges and public health implications, particularly unique to children and families. So there's housing instability as these eviction bans are being rolled back. There's a childcare crisis as employers are returning to office and people are juggling how to get back to work. There's food insecurity because many of our children depend on school attendance for nutrition. There are behavioral health issues. There's an epidemic of depression, anxiety, and eating disorders. And there's a problem with access to timely behavioral health interventions. We're seeing skyrocketing rates of obesity and type 2 diabetes in the pediatric population because of the fact that they're not doing the normal level of sports and physical attendance of recess and all those things. And then just learning loss, and particularly our Black and brown students that are disproportionately impacted by virtual instruction and the pandemic, and what will be the long-term health impact on health literacy and health outcomes. These are all secondary but really important impacts of this disease on the pediatric population. Next slide. So, you know, in summary, we've tried to lead at Children's National with regard to the pediatric specific issues, whether that be testing, access to testing with a dedicated ambulatory site. I can guarantee you it's harder to get a swab on a small child than a cooperative adult. And we have that expertise and used it. Clinical care, optimizing what we learn in adults is not always the same for children. The dosing is different. How we apply those to the pediatric population is different. Coordinated institutional emerging infection response, education, not only for our own staff to keep them healthy and well-informed, but using the national press responsibly to counter misinformation, as has been talked about, and to calm parents so that they get good information and can make good decisions for their own families. And then our research response and our participation in vaccines, in particular, particularly important to look at equitable and safe distribution of vaccine in pediatric populations. So my last slide is just an acknowledgement for all of the groups that work in and day out at Children's. And this has preceded COVID. Our special pathogens team really has been together since Ebola and Zika and many other emerging diseases. Our infectious disease and control divisions have really honed their skills even more with COVID, and then our disease-specific task forces that have led to the collection of all this information. So thanks, I'll end there and will be ready to participate in the panel.
Thank you so very much, Dr. Dibiase. I am looking forward to that panel discussion to talk with you about the difference between recognition and panic. But now I'd like to welcome Dr. Hooper and her very important comments. Dr. Hooper, thank you for representing this important content.
Thank you. Good day, everyone. I'm delighted also to be here with you, participate in this panel. So I want to start by thanking the meeting organizers for the kind invitation. Next slide. So just a quick note before I get started. Next slide. So I am here to discuss health disparities. So let's start with a key definition. Health disparities. These are not just any type of health difference. These are a specific type of health differences. And I think the distinguishing factor between health disparities and other forms of difference, such as population differences, is that disadvantage is the causative agent. Multiple levels of disadvantage, such as social, economic, and environmental. The population to experience health disparities are those who have faced systematically greater obstacles to optimal health. We can characterize these groups in a number of ways. These are groups that are often discriminated against or excluded. And importantly, and in contrast to general population differences, health disparities are differences that should not exist, that are modifiable, which means that we have the opportunity for change. Next slide. There are considerable racial ethnic disparities in most conditions. These disparities include shorter overall life expectancy, higher rates of cardiovascular disease, cancer, diabetes, infant mortality, stroke, cognitive impairment, asthma, sexually transmitted infections, dental diseases, differences in the prevalence and outcomes of mental illnesses as a few examples, and now COVID-19. Next slide. So in May of 2020, the director of the National Institute on Minority Health and Health Disparities, our scientific director, and I published this viewpoint in JAMA, which was among the first to write about racial and ethnic COVID-19 disparities. The article has been cited an astounding number of times in a very short time period. And the main points of this article were that the pandemic put a spotlight on health disparities for all to see, created an opportunity to address the root causes of underlying inequality, that the strategies that are culturally appropriate and community competent are needed, that consider the nuances of populations, communities, family, individual differences, all that have a vital role in reducing health disparities, not only in COVID, but in general in terms of the promotion of health equity and improving population health. And then we also pointed to the need for studies that are guided by the science of community engaged intervention development, implementation, and evaluation. Next slide. And, we saw early on that there were, despite the data being incomplete, there have been consistent reports of disparities by race, ethnicity in COVID-19 cases, outcomes, death, hospitalization, where most racial ethnic minority populations are facing a disproportionate burden. Next slide. And in addition to racial and ethnic minoritized groups, there are other individuals who are more likely to experience worse COVID-19 outcomes. So evidence to date indicates that selected underlying medical comorbidities, serious illnesses, including those that you see here, are associated with more severe COVID-19 outcomes. Next slide. And the risk of death from COVID-19 increases as the number of comorbid medical conditions increases. So people with even one comorbid condition, such as the ones listed on the previous slide, have a 50% increased risk of mortality, and it goes up from there. So it is essential that we do everything possible to prevent COVID-19 for everyone, and especially the most vulnerable to face medical complications and death. Next slide. So why do these disparities exist in COVID-19 and other diseases? I think the COVID-19 pandemic has been the first time that many people have witnessed a new wave of health disparities emerging in real time. And so it provides a good opportunity to discuss these issues. Medical comorbidities is the answer that we hear and read about often from scientists, physicians, health officials, and indeed, racial, ethnic, minoritized populations have a disproportionate burden of underlying comorbidities. The problem with this explanation is that it is absent the full context of the pandemic. Race is a sociocultural construct, not a biological or genetic one. And race is important to study because it shapes the lived experiences of all groups. So it's important that we zoom out to view the full context, which includes looking at systemic factors such as historical and ongoing discrimination, things like chronic stress and its effect on immunologic functioning and health, and other factors. Next slide. So this is a model that I developed early in the pandemic to help me conceptualize the interrelated factors that are contributing directly to COVID-19 cases and outcomes. These factors can be themed as related to health and healthcare, socioeconomics, and social determinants of health. And the model depicts this backdrop of structural or systemic racism and discrimination, which directly impact health and all of these factors. So a key point is that disparities in COVID-19 are not because racial and ethnic minoritized groups are inherently more susceptible to the virus, but because of social inequities that have led to more pre-existing conditions, such as heart disease, diabetes, HIV. So there are structural issues taking place here rather than inherent biological or genetic underpinnings. Next slide. Other point I wanted to make, and this leads to the SEAL initiative, is the issue of trust. And we know that trust is an underappreciated social determinant of health. And so when COVID really highlighted distrust in addition to the social justice issues happening in the country. Next slide. So the SEAL initiative, SEAL is the Community Engagement Alliance Against COVID-19 Disparities. It is an NIH-wide initiative stood up in the summer of 2020 to lead outreach and engagement efforts to address distrust and mistrust, particularly in racial and ethnic minoritized groups who were disproportionately impacted by the pandemic. And addressing disparities and the diversity in clinical research trials, particularly COVID-19 vaccine trials, was our immediate priority as those trials were launching in the summer of 2020. And we knew the importance of diversity in the trials. We also knew that barriers such as distrust and social determinant factors would be things that we needed to address. Next slide. So this lack of diversity in clinical trials is just not a new issue at all. This is just one of many examples I could show you from a kidney cancer therapeutic trial. And the bottom line message I want you to take is that of the 821 total participants in the trial, only 5 identified as Black or African American, and that's fewer than 1%. This trial was published in 2015. Next slide. So a question that we've focused a lot on, I think, over the past year and a half is how do we increase trust in biomedical science and healthcare? It's a complex, it has a complex answer, although it's really a kind of fundamental question. And we do know that, expertise gained from multi-sector stakeholders, including those from affected communities, is important, that we need individuals who can deliver the right messages, and community groups and other experts are among the right messengers to help build trust. And these stakeholders also have really important insights. And I've also listed here some strategies such as diversifying the team, setting a priori targets for recruitment. And I won't read all the strategies, but I just want to point to the last one, which I think is an under-focused on strategy for the efficient recruitment and diversity in trials, is that we simply have to ask people to join a study. And just ask. I think that'll make a big difference. Next slide. Wanted to mention this as one of the first efforts was working on the Moderna Cove study, which was launched on July 27th of 2020, just as SEAL was forming. NIH leadership worked very closely with Moderna to focus on increasing the diversity of their enrolled participants. We provided direct guidance about the various strategies that I've mentioned, And what you see over time is that the blue bars are increasing. So the diversity of the trial in terms of racial, ethnic, minority inclusion increase with intentional efforts to address these issues using the strategies. Now, NIH cannot take full credit. Moderna did the work, but we certainly believe, and Moderna has acknowledged the role that NIH and SEAL played in the diversity of their trial. Next slide. So these are the final data on the diversity in the COVE study. And you can see that the proportions of racial, ethnic, minority persons were respectable, much better than what we see in most biomedical trials, industry or NIH funded. So we're pleased with that. Next slide. The SEAL initiative is ongoing. I encourage you to take a look at the website, which I'll also give you on the next slide. We have 23 geographic locations. They are all focused on addressing the surging cases and the ebbs and flows of surging cases and this overall disproportionate burden of COVID-19 in the populations of focus. SEAL really is about the ground game. It is about being on the ground, doing the work to increase trust in science and to accelerate the uptake of beneficial interventions. The website is here. It really is an evolving website, which has a repository of very valuable information to help combat the COVID-19 infodemic. The materials are available in multiple formats, and they're available in Spanish. And our goal is for these resources to be shared as widely as possible, even beyond the SEAL Alliance. They can also be customized. They're free for customization for local or community context. Next slide. So finally, I want to leave you with a few important thoughts. We need to recognize that racial and ethnic minoritized groups in general are just as willing to participate in clinical trials. Several well-conducted trials demonstrate this, and our institute could not exist if that were not the case. So it's important to dismiss the notion that these groups are just not interested in participating or just hard to reach, one of my least favorite phrases. And we need to think about what approaches that we can take. What are some of the best approaches that we can use to better reach communities that have been marginalized? And maybe we just haven't done enough in terms of the healthcare system and researchers to ease the minds of populations around research and to address that institutional distrust that exists. Next slide. I also just want to point out that I conducted this interview with my parents-in-law in late 2020. They are participants in the Moderna trial, and I wanted to share this conversation about their experience in the trial because unlike what you would surmise by watching the news, reading articles about underrepresentation in clinical trials, about vaccine hesitancy, they really showed the diversity within the African-American community in terms of beliefs about trial participation and accepting COVID-19 vaccines. So we shared this discussion in hopes that it will help others. Next slide. So I'll end here. I invite you to connect with NIMHD and happy to answer any questions that I can. Thanks.
Truly excellent, Dr. Hooper. I thank you so much for today. And I now want to welcome Dr. Lamas, Dr. Dibiase, and Dr. Hooper to the panel discussion. Dr. Jha is not able to join us, but may I also invite all of our participants to submit questions in the Q&A. I will try to keep an eye on that and pose your questions as well. But I'd like to start with Dr. Hooper. You mentioned that it's very possible that the pandemic will present opportunities. And I wondered how you can address a very sad experience like a pandemic with the public and think about it in terms of opportunities.
Yeah, I think that the pandemic, because it has laid bare inequities in the healthcare system, the disconnect between public health, science, and medicine, it is what we think of as an opportunity. So at NIMHD, which has been in existence for 10 years or 11 years as an institute, but in total, our office, before it became an institute, for 30 years, we've been really focused on this topic for a long time. And I think those of us in the field have always recognized its importance. But in terms of the national attention and the discourse about disparities, we are seeing this at levels that we just haven't seen before. So that's the opportunity to help inform, educate, and importantly, think about ways to address and to fix these inequities, because they don't have to exist. We just have to be intentional about addressing them. And I think that's what we're really focused on at our institute right now.
I want to commend you on a one-word message, ask. Beautifully stated. I can't praise you enough for that. Now I'd like to go to Dr. Dibiase. And Roberta, you mentioned the importance of giving information, of updating information, even on serious news, but not creating panic. Could you speak to that a little bit more, particularly from the family perspective in pediatrics?
Yeah, it's been a real challenge because so, everyone I think in the community is very aware of the severe impact on adults and particularly on the elderly. So that's sort of the background that they have, that their knowledge of COVID was. So as soon as they heard that it wasn't really that serious in children, or not as serious, there was almost a out of sight, out of mind attitude about, well, it's never going to happen to my kids, and I'm just not going to even think about it. However, then the news would counter that with the most extreme, severe, fatal in some cases that certainly happen in pediatrics. So it was almost like the parents were getting really two very wrong messages, one of which was don't worry at all, and the other which is every time your child gets sick, they're going to end up, critically ill and die. And so that was the line that we as pediatricians have a hard time to communicate, because the last thing we want is for our families that already maybe have difficulty getting to care to begin with, to not even have it on their radar that their child in front of them who's really sick, but someone has told them, well, don't worry, that they wait 3 more days, and then that is the child that's going to die of MIS-C if they don't get to the hospital. So we wanted to give, the way I would do this in interviews would be to give people the true information, but then empower the parent. You know your child more than anyone else. If you see your child looks really sick, you need to know that children can get really sick, and you should use your knowledge of your own child to get them to care. So not just saying, well, you need to just rush to the ER every time your child looks sick. Use your own knowledge of your child. And when they are sick, know that they could really be very sick. On the other hand, if your child looks pretty good and has a runny nose and a cough, guess what? That's 97% of what children with COVID look like. And you should empower yourself to not panic and rush to the ER because your child has a runny nose and a cough. So that's really sort of how we have navigated that. And then as Dr. Jha mentioned, I'm a mom, so I always give my own, experience. This, Pam, when I give the weekly situation updates, my last slide is something that happened in my own family, because it really does help people to see that we are navigating the same information in our own families and with our own kids.
Thank you for that. I'd like to invite the three of you to talk with each other and all of us about the word that you mentioned, and Dr. Jha did as well, and that is trust. How is it that as scientists, we can touch on trust of us, trust of our words, trust in communities, trust in systems? I'd like to invite each of you to speak to this word and the strategies that within your own experiences you have found to be helpful, or strategies that you wouldn't choose to use again.
I can start. Oh, go ahead. I think Daniela, you're on mute.
Oh, no, I said, go ahead, because it seemed like you were starting, and I was like, all right, excellent. Okay.
I was just going to say, I learned a lot. We all have our ideas about if we're trustworthy or not, and how we convey trust and build trust with our own patients. But when we're talking at a population level, not with our own specific patients, I think the most important thing is that we have to realize, why should someone trust me if I'm not coming from their background or their belief system, or, whatever, well, of course you must trust me. No, that's not the way to approach trust. And I learned a lot from being on the DC vaccine advisory committee for safe and equitable access, because on that committee, I think I was the only physician and scientist. Really, the other 25 people were from religious organizations and volunteer organizations and all sorts of groups that have very important, more important than mine, perspective on how their constituents view the vaccine and what their issues were. So that's how I learned, to build trust with different groups of people, by learning from them what it is that they're actually worried about, not just assuming that what I'm telling them is what they're worried about.
Thank you.
I'll add that, trust is, as I mentioned, a very underappreciated social determinant of health. And I think, I'm a clinical psychologist, and in the work that I've done and what we know from the psychological literature is that, and you can think about it from also a personal perspective, trust is a very complicated cognitive and behavioral and emotional topic. And once trust has been damaged or broken, it is very hard to have that back. How do you get trust back? You have to earn someone's trust. If someone, if anyone in your life has ruined, has lied to you or has in some way damaged that relationship, they have to really work hard to get it back. And I think the pandemic put us in a situation where, because we had not addressed longstanding distrust of a number of populations, now we're in a crisis and we want automatic trust. And that's just not how trust works. And we have to consistently work to earn trust by not only giving our evidence-based information, because we're scientists and we should believe you and you should believe us, but there has to be more of a dialogue to understand the sources of the concerns. We have to affirm and acknowledge what has happened previously, why this might be different. And what I have found is it really is a dialogue. It's giving individuals an opportunity to ask the questions they have, to express their concerns, and have the respondent be non-judgmental in how we respond to that, and provide, validate and affirm, but then provide corrective information and acknowledge that it will probably take time before we actually start to see change. And I think even in the example of vaccine hesitancy, which in part has to do with mistrust or distrust, we've seen that change over time. So it's something that can get better, but it does have to be something that is a consistent focus.
That filling the void, the uncertainty, the silence with effort such as facts, figures, but also the valuing of what's important to the other person, the listening, the dialogue. I appreciate that. Dr. Lamas.
Yeah, I mean, I was going to speak sort of, I guess, I can address the kind of at the bedside type of more rapid trust building that
Yes.
Needs to happen often in the ICU, but sort of much more acutely in these scenarios, particularly given everything that was going on outside the ICU as well. And I think the point that you made about uncertainty is really key because very often in critical illness in general, but also in critical illness with a novel virus, there is a lot we don't know about what might be ahead. And I think sort of the willingness to acknowledge that on both sides, like sometimes it's worse than we think, but also sometimes we're wrong and the person does better than we think. And sort of like being able to acknowledge that while also not being entirely just, I don't know, who knows what'll happen is like a very hard balance to strike. In terms of building trust, sometimes it has to happen really quickly. Like sometimes something has to happen in, minutes or hours. And there is almost no choice because there's a decision that needs to be made. And to whatever extent you are trusted, a decision needs to be made and you make a recommendation, the patient, the family takes it or not, and things happen. And then sometimes you can build trust over days, or trust gets eroded over days to weeks as a family feels, as they did often in some of these families in the pandemic, that we weren't trying hard enough, that we had given up, that we were forcing them to consider transitioning a loved one to comfort, things like that. And so I was thinking of a particular example that I'll tell very, very briefly, that there's a patient who took care of like maybe a winter ago who was a mom, had a couple sons, families from somewhere in Central America, but lived in Boston. And she had gotten sick with COVID, got better, went to our long-term acute care hospital, got a bad pneumonia. So when she was sick and got better, they said she's never going to make it. She made it out to the long-term care hospital, got a bad pneumonia, came back into the hospital, and now was dying. Her lungs were just like cement. Like there was no way that things were going to be okay. Her kidneys failed. Her sons were at the bedside and they said, I need you to give her this sort of medicinal supplement called silverflower. And we Googled it, and it was on like an FDA list, like this is not useful at all for COVID, probably not harmful, but we have no idea. But they'd ordered it on the internet. They'd spent a lot of money for it. And they wanted us to give it to her, one sort of drop a day from a dropper for like 14 days or something like this. And there was this whole back and forth where, well, one of the ingredients maybe could cause liver injury, but like, did that even matter? And like we were so sure this had no use. It was treating the family, perhaps. Was it going to harm the patient? And so there's this huge sort of dilemma about it. Ultimately, we decided to give it. She did not get better, which was not surprising. And they kind of didn't follow through the 14 days, but it was this interesting moment, like, how do you build trust with these people? And what does it mean if building trust means doing something that you don't actually even think is useful for your patient? Like, is that right? And so that was not a clear answer to your question, it was more questions, but there's a lot of, when you are trying to bring somebody to a point where sort of the gentlest way possible toward an outcome that nobody wants in a scenario where you're not trusted as a medical team or more broadly as a medical system, you find yourself in very sort of uncomfortable situations.
All three of you were placed in urgent situations to develop trust and for large groups. I want to thank you for stepping right into that. Were there strategies that you would not use again?
I think false certainty doesn't help at all. You want to feel like it is easy to feel as though, well, somebody will trust someone who seems to know what they're saying, who, gives you the information about what will be ahead, who tells you things will be okay or won't be okay. But when there is uncertainty, honesty and acknowledging uncertainty is definitely better in the long run, and giving people time if there's time to be able to give in order to build trust.
Dr. Hooper, Dr. Dibiase, something you would not do again?
I think, over time, as we're just bombarded over and over again with new things to learn and change, we get tired, and I think, I say I won't do this again, but there have been days where I'm like, what, if you don't want to get vaccinated, I give up.
Yeah.
What else can we do to get you to get vaccinated? We've given you all the information. I've tried personals, so I would try not to do that again, because I think that sort of just defeats the whole purpose of what we're trying to do. If we fail every day at convincing someone to get a vaccine, that doesn't mean that we should, give up. But we have to recognize that we're people too. And, we get tired, and we probably just need to step back when we feel like that some days. I was at another meeting and they were talking about self-care strategies for physicians. And one of the take homes was that, a lot of people seem to be using more alcohol than they should. And so we were all talking about different strategies that we should be using. And I remember clearly one day I was trying to deal with one of those days where I just, I was having a hard time. It was winter. So I think I had at the same time, I had a candle and aromatherapy. I had a sun lamp. I had maybe a bottle of wine later in the day. I don't know. But, I think we have to remember that we need a lot of different strategies for self-care so that we don't make that mistake of going into a situation where we're feeling depleted, because it doesn't help us and it doesn't help the people that we're trying to help.
I very much respect those words. Dr. Hooper.
Yes, so I'm in a bit of a different context where I'm not in a clinical setting and seeing patients, but I will say at the NIH level, I probably would, in hindsight, have pushed more for strategies and interventions that are not simply information based. And we focused a lot on education, and with the assumption that providing education would be sufficient. And I know from my own work, as a psychologist, that would not be sufficient, particularly when trust is low to begin with. That's just like someone who you don't trust telling you the truth. And even though they continue to say it, if you don't trust them, that's not sufficient because their word doesn't mean as much. The other piece of this that I think has created some issues is that because the information changes almost on a daily basis, if their trust level is baseline low, you give information, people try to hear that, take that in, and then the information continues to change. It doesn't bode well for trust building, although that's the context that we're in. And so really requires a much more nuanced approach to addressing trust than I think we took early on in the pandemic.
I very much respect those words. It makes me think about Dr. Jaw's words about stepping in, offering information, but knowing when to step out or when to hold. And we need a little bit of refinement on those thinking, with those opportunities. When do you step in? When do you step back? Very important knowledge that we could learn about that. I do want to share with you that we have a couple of questions from the audience. And here's the first one. As public health is prevention and population oriented to halt the spread of communicable disease, is COVID-19 teaching us the need to educate more about the treatments that have been used successfully, such as monoclonal antibody infusion, at least up until now?
I mean, I can give my opinion on that, and
Thank
Dr.
you.
Lamas may, she's using a lot of the therapeutics as well. So, I think, again, it's the balance of the treatment and the prevention that's difficult. I think most of us believe that it would be more useful and more achievable to have people vaccinated and prevent severe disease than to have full access for everyone to monoclonal antibodies once they're infected. I think, that's probably what most people believe, and I think it's probably based on fact. But there's still going to be a subset of people who don't want to be vaccinated. And should we then deny them access to monoclonal antibodies if they get really sick? I think that's an ethical question, So I'd be interested to hear what Dr. Lamas thinks about that.
Yes.
No, I mean, I think everything you said is totally true. And not only is there the subset of people who don't get vaccinated, who I think we, if we were in a different system, ethically, perhaps we could make those determinations, but would we even want to, right? Because like the reasons that people don't get vaccinated are so varied, and in some cases are based in the exact types of sort of distrust from systemic inequities over generations. And so there are all these conversations now about like, should people who got COVID as a result of actively declining vaccination and need a lung transplant, like not get transplanted? And I would argue that if they are otherwise transplant candidates, they should be listed for transplantation. But anyway, in terms of the monoclonal antibodies, yes, like the data for monoclonal antibodies are good. It wouldn't just be, and not just for patients who don't get vaccinated, but also for patients who are sort of high risk, immunocompromised, patients who have conditions that would make it challenging for them to mount an antibody response. There's even like, this is not the case currently, but there's some talk about at some point, would there be like sort of post-exposure prophylaxis and monoclonal antibodies, like, all right, I think I was exposed to COVID. I'm a high risk. Like, should I get this? That's not the case right now. And access to monoclonals is still variable depending on where in the country you live. It's sort of challenging, and how much kind of medical knowledge and wherewithal you have to, like in LA, some people call up like a service and go to their home. That is not the way it should be. And so there are challenges with that.
I'd like to follow up on, oh, please go right ahead.
Oh, no, I was just going to say, but I don't disagree with I agree with the fact that like it is prudent for the main conversation to be get vaccinated. And so if we feel like we're not getting enough information about monoclonal antibodies, I think that's an interesting point. And I think that is sort of a gray area, and it's a tension of like, how much do we want to talk about this thing that people were often using in lieu of vaccine, which isn't our goal at all. And it's not smart. So, yeah.
I'd like to give you the second question, and if we have time, to follow up on the important statements that all three of you have made. The second question from the audience: ethnic, racial underrepresentation in clinical trials is underestimated in international studies. Could you comment about this?
Sure, I'm happy to start there since I brought this topic up. I agree that that is true. And I think one of the reasons is that depending on the country, race and ethnicity are different than they are in the United States. And in some countries, race and ethnicity is not something that can legally be asked. And it's not like in France, conducting studies by race ethnicity is illegal. So it really does depend on the country and the context. And even in the COVID-19 vaccine trials, some of which were conducted internationally, it's important to look at the data by, in South America with South American Latinos and make sure that we kind of separate that from US Latinos, because there are some differences that we need to think about, not from a genetic or biological perspective, but from what race means for your health perspective, which is different. And I think, though, that across the board, what you see is that even in other countries where the representation could be better and the population is not fully homogenous, like in some European countries, for instance, there's just not an emphasis on it. So it certainly is an underestimation, but you don't see an emphasis on this topic as much as we need to have. And but the groups and the way people would describe them, it's not a one-to-one, because what ethnicity means in the United States is different from what ethnicity means or race, even if it exists, because it's also social, that it differs. But it's important that each country's context thinks about it and ensures that there's adequate representation within the population based on the census and the demographics, and also based on the disease burden. We want the trial representation to match the burden of diseases. And that should be true, I think, internationally as well as domestically.
I'll follow up on that.
Yes.
The big trial I was telling you about that we're doing with 1,000 kids that are affected in 1,000 contact or healthy contacts. It's really important what she talked about that NIH did with the vaccine trials, with all these trials, that every metric in every meeting includes, when you're looking at your enrollment and your recruitment, includes all of these different categories, because you can easily, recruit half through your trial if you're not specifically looking at and optimizing and modifying the way you recruit to make sure that you are actively capturing all the populations that need to be in your study. And for COVID and MIS-C, I told you, at our center, our MIS-C patients, 85% are either African or Hispanic. So if we're only recruiting white children into the MIS-C study, that is completely missing the boat of what happens. But there are real things that have to be changed. So if it takes 3 hours for us to recruit on average, from beginning to end, get someone into our study, if we now add in that they're Spanish speaking only, that it's difficult for them to get to a phone, that it's hard for them to make it to their appointment, it means that you have to factor in 4 times as many personnel for recruiting than you thought you needed to make sure that you are capturing all of the populations that need to be represented in that study. It's really, really important, but it takes an active, ongoing effort.
I'm incredibly grateful to each of you. And I know that I now need to surrender this conversation with you. But I want to thank you each very sincerely for what you're doing and what you're planning. I really appreciate what you're anticipating and the presence that you are giving to this conversation. I thank every one of you. And now I'd like to welcome Dr. Wong.
And thank you, Pam, for your skillful facilitation, and to our speakers, Dr. Jha, Lamas, Dibiase, and Hooper, for a compelling discussion. We will transition now to session 2, Building on Lessons Learned to Guide Future Health Policy. Our moderator is John Broyles, the Executive Director of the Coalition to Transform Advanced Care. Take it away.
Thank you, Susan. What's it going to take to implement the new CMMI refresh strategy as an accelerator for value-based payment models for serious illness care? How do we ensure health equity is part of the future of care models and payment models? And what are some important trends that we should all be aware of that are going to impact policy moving forward from the pandemic, such as the growing presence of private equity in healthcare delivery and in this space in particular of serious illness? And we can't forget the burnout of many, many frontline workers as a trend to track. I am happy that I don't have to answer those questions all on my own, that we have a heavy hitting panel for you today. Format is we're going to have in two initial presentations. The first by Purva Rawal, who is the Chief Strategy Officer of the Center for Medicare and Medicaid Innovation, CMMI, followed by Joe Rotello, who is the Chief Medical Officer at the American Academy of Hospice and Palliative Medicine. Then we're going to go to the panel discussion. We're going to get into the thick of this with Rick Gilfillan joining us at that time, who's an independent consultant, a family doc, and the former CEO of Trinity Health, and the first director of CMMI. So a stellar group. We look forward to the discussion. And Purva, I'm going to turn it over to you.
Thanks, John. I'm really happy to be here today, especially with Joe and Rick and John, who are real experts and leaders in this field. So I'm gonna, I think we can go to the next slide. I'm gonna start at the very beginning here, which Rick is very familiar with as sort of as the first director of the CMS Innovation Center. So I wanted to just kind of start at the very beginning, give everyone a little bit of kind of basic information on the CMS Innovation Center and our statute. And the statute explicitly provides CMS the authority through the Innovation Center to test innovative models. And the goal of these models is to preserve or enhance the quality of care for beneficiaries in Medicare, Medicaid, and the Children's Health Insurance Program while spending the same or less. And if the model is able to achieve one of the three scenarios listed here, to improve quality and maintain cost, to reduce cost and maintain quality, or to reduce cost and improve quality, the Secretary of HHS can expand that model, including expanding the model nationally. Next slide. So that's been the statutory mandate for the center since it was established in 2010 through the Affordable Care Act. And that last decade has really, there's been a lot of innovation and a lot of new models that have been tested. So, part of the goal of the strategy refresh, or the new strategy now that we've been implementing over the course of this fall especially, the goal has really been to use the learnings over the last decade to think about where the Innovation Center can be headed next. How do we use the statutory mandate to develop new models and to inform the development of new models, but how do we also think more broadly about the Innovation Center's ability to impact broad system transformation? So in that spirit, since March of this year, my colleagues at the Innovation Center have been engaged in developing the strategic refresh. I came on board in mid-August, so they've been working hard for 5 months before that, before my arrival. This is, what they did was took a very critical review of what's been accomplished over the last decade. Over 50 models have been launched by the Innovation Center. Nearly 30 are still in operation. Only a handful have been expanded, but there have been many lessons learned. And then in addition to looking internally, they also look to other experts across the department and CMS and to external experts and leaders in health policy and healthcare delivery to inform the refresh that I'm going to be walking through with some of you, with you all today. And as you may have seen, the framework for this new strategy was laid out, that started in a blog post in Health Affairs in August. And since then, we've published a white paper that describes our objectives and goals in more detail. I'm going to walk through some of them now. And John actually hit on some of these points in his opening remarks, especially equity. So the purpose behind the strategy effort on the blog, the white paper, is really to chart a path forward for this next decade that provides more guidance and clarity for where the CMS Innovation Center is heading, and also to increase momentum, in the movement toward value-based care, and to reignite some of that sense of inevitability that I'm sure Rick and his team at the Innovation Center felt back in 2010. I think there's been a little bit of a slowing down of that momentum, and maybe some not so clear signals to providers and beneficiaries about where we're headed. And so that's really one of our goals here, is to reignite that sense of inevitability and momentum, and create some clear signals for where the Innovation Center is headed. One of the other goals was really to think about to be able to create a more streamlined and harmonized portfolio of models that's able to drive to the broad system transformation I referenced just a few minutes ago. So, there's individual models. There's been a lot of learnings from specialty models, from Hickey Awards, a lot of the work that's happened over the last decade. And now how do we take some of those learnings to really create maybe a smaller set, but a more harmonized set of models? And then we have a renewed vision to really achieve equitable outcomes through high quality, affordable, person-centered care. And that's the spirit in which we've really organized the strategy around around 5 objectives. These objectives, the first 3 of which are here that I'll talk a little bit about, are really guiding our model development and conceptualization already, our priorities, and they're really going to dictate how we measure our progress on achieving the goals that we've set out. So the first objective is driving accountable care. So it's really the central goal of the Innovation Center to increase the number of people in relationships with providers that are accountable for their patients' costs, and for most importantly, for improving their care. So this is going to require increasing beneficiary access to both advanced primary care and accountable care models that are equipped to coordinate the care of beneficiaries and integrate with specialty care, so we can make sure we're meeting the full range of patient needs, which is something that I think this group is, one of the challenges this group I know is familiar with. The second objective is advancing health equity, which again, John had referenced early on. This has become one of the most important areas of focus for the Innovation Center, also for CMS and for the department, for HHS more broadly. And it's really part of our, as part of our strategy to improve quality. We're committed to embedding equity into all aspects of our models and really increasing our focus on underserved populations. And we know that we can't improve quality without addressing equity upfront. We're going to rely on a number of strategies to promote health equity in our models. We have to get the question, how are you going to do that? So this really, this includes, for instance, addressing barriers to participation for those providers that serve and care for underserved and rural beneficiaries. This could be, those, practicing in HPSAs or medically underserved areas. We are talking to and committed to engaging a broader range of provider types, safety net providers, including FQHCs, rural health clinics, and others. In order to achieve our accountable care goals, we know that we have to have more providers and different types of providers in our models. The third objective is supporting innovation. So we can also do a lot more to support our model participants that are looking for ways to innovate care delivery approaches. And obviously, there's a lot of exciting work and innovation happening in the wellness space as well. Some of these supports include actionable and practice-specific data, how we're using technology, the dissemination of best practices, peer-to-peer learning collaboratives, and payment and other regulatory flexibilities. I would say oftentimes we think of those things as tools to support providers, but we just want to kind of underscore that those are really mechanisms for achieving the goals, which is better care, better outcomes for beneficiaries. You can go to the next slide. The fourth objective is addressing affordability. So in addition to our payment models, we know that, and there's obviously the statutory mandate that I went over at the beginning of my remarks. We know that we have to be designing models and thinking about the impact on reducing or at least keeping even expenditures in Medicare and Medicaid. But we also know that our models can have an impact in some cases on lowering patient out-of-pocket costs. And it's really important for beneficiaries and for families and those caring for them. And so this is our priority across CMS, and we're going to be looking at strategies in the context of our models to target healthcare prices, affordability, and reduce unnecessary or duplicative care that can increase costs. And then the fifth and final objective, I think, is really, they're all important, but excited to be talking to you all here today about this one in particular. You know, the last part of our strategy is aimed at furthering the reach of transformation. So this is a big, I guess, a bold strategy. One of the questions I think we've gotten the most is, this is great, but how are you going to do it all? And the truth is we can't do it alone. So we really want to be able to align our priorities and policies across CMS, so working with our colleagues, closely with our colleagues in the Center for Medicare, the Center for Medicaid and CHIP Services, but also working with experts, beneficiaries, patient groups, payers, providers, purchasers, you know, to achieve our vision, because we know that it's going to take not only a shared vision, but shared commitment and action to be able to move forward. So to achieve the goals that I've just laid out under each of the 5 strategic objectives, we're going to need to undertake some other key changes, and our white paper went into some of this, or some ways that CMMI would also like to do business differently. So first, we are strengthening our communications with stakeholders. We want to be able to integrate the patient perspective into our work across the life cycle of our models. So not just at implementation or even evaluation, but when we're conceptualizing a model, when we're developing it. And, you know, would welcome the group's thinking here on ways that we can do that. We also really want to understand both the barriers and facilitators to providers and plans participating in our models. So this means not only talking to our model participants, but finding those folks that have, you know, participants that maybe that have dropped out of our models or couldn't join in the first place. Because if we want to, again, reach our goals for accountable care and advancing health equity, we're going to need to understand and address the barriers, and that so that more folks can cross that threshold into value-based payment and then be able to sustain their participation once they're in. And so, you know, some of the things that stakeholders here can expect. We just had our first general listening session coming out of the white paper. I guess it was 2 weeks ago now, or almost 2 weeks ago. We had over 1,200 participants. We had 15 members of the public speaking and provided, you know, comments for 3 to 4 minutes. We found it extremely helpful, and that was just kicking off what's going to be a long-term kind of set of listening sessions that we're doing. We have another one on December 8th that's going to be led by our Chief Medical Officer, Dora Hughes, on health equity. So if you haven't seen that, you know, happy to share that information as well. And we're going to be looking for other opportunities to conduct outreach with experts, you know, with groups on various issues, including all of you, and you know, also open to new ideas for ways that we can be soliciting input. The second piece of what we want to be doing differently is trying to generate a more dynamic, you know, sort of a more dynamic generation of learnings from our models, including with external researchers and experts. So of course we have our own evaluation group, there are contractors that we work with, but you know, part of our goal to achieve the health system transformation really we're not going to be able to achieve that without a more kind of, you know, augmenting our own evaluation findings and learnings with external researchers and experts. So our team, our data teams are piloting efforts to share research identifiable files via, you know, CMS's VRDC. We're also identifying and preparing additional files to enhance the data that are available in the VRDC for further analysis and research. And then last, you know, as I said at the beginning of the call, our North Star will continue to be testing successful models that can be expanded to reduce program costs and to improve quality and outcomes for Medicare and Medicaid beneficiaries as our statutory mandate. But we also want to mind the other impacts of innovation center models that may not necessarily rise to meet the criteria for expansion, but they are nonetheless, we believe, contributing meaningfully towards health system transformation. And so moving forward, we want to consider the success of our models more broadly. And this could include, you know, how our models are impacting beneficiaries and families in terms of their own patient or caregiver experience, quality of care transitions, access to home and community-based care. How are our models impacting providers in terms of their ability to move down the transformation pathway? Does it have an impact on their administrative burden? Do they have access to more timely and actionable data that informs care delivery? And do they have new tools, or are they able to use tools differently to facilitate clinical transformation and care integration? And then we also want to be thinking about how our models impact healthcare markets through factors such as, our models creating new linkages or relationships between providers. Are they having impacts on consolidation? What's the spread of successful elements of models to other payers? And how can we be looking at scalability to other regions and payers? And so we really want to be kind of defining our success a little bit more broadly and thinking on the front end more deliberately about the potential for models to have these broader system impacts. So with that, I will stop and turn it back over to John.
Now I'll turn it to Joe. Joe, welcome.
Thank you. We can move to the next slide. It's really exciting to be part of this wrap-up panel, and it's great to hear from Dr. Rawal about the strategy refresh. For my part, I'm going to zoom out a bit and then really try to just make the case for why now is the best time ever to invest in quality, in workforce, and in payment models that will work for people with serious illness. We've heard a lot about what we've learned during the COVID-19 pandemic. I'll just pick up a few of those themes. There's been a disparate impact on communities of Black, Indigenous, and people of color. And there's been a disparate impact on people with serious illness. We've actually seen that innovation can happen much faster than we ever thought. We've talked a lot about how information has been slow in coming and there's been a lot of uncertainty to deal with. But one thing that's truly remarkable is how quickly the mRNA vaccines and other vaccines were developed, faster than we thought was possible. So we're learning that maybe there is a more rapid cycle to innovation. We've seen more care provided in the home. Next slide, please. We've seen an explosion of telehealth. It's like telehealth jumped ahead a decade because it had to. We've seen that workforce and supply shortages that pre-existed the pandemic got worse. And we've seen that a real issue with clinician distress, whether it's burnout, moral injury, that we have even more of that now to deal with. But many of the problems that we've seen pre-existed the pandemic. Next slide, please. So I'm going to zoom out and go back, just as Dr. Rawal went back to the statute that that created the Medicare and Medicaid Innovation Center. I want to go back and talk about why it was needed. We do have a value imperative in our healthcare system, and serious illness is part of it. The simplest way that people define value is that value is quality over cost. When all this was starting a decade or more ago, the Institute of Healthcare Innovation and Improvement, IHI, had their triple aim. And we did a lot of talking about the triple aim: better outcomes for populations, better experience of care, and lower costs. So now quality is broken into two parts: better outcomes and better experience of care. Why do we need this? Well, we can look at today, the most recent study published by the Commonwealth Fund, and I put the link at the bottom of the slide, of the 11 highest income nations. The US ranks last in healthcare outcomes, but we rank first in healthcare spending. So even a decade later, after the creation of CMMI, after the move toward value, we're still lagging. We don't see value that comes along with the high spending. Is serious illness part of that? Absolutely. Folks with serious illness are associated with poor outcomes and high costs. Do we know things that can impact that? Yes, we know that palliative care improves outcomes and often lowers costs. But palliative care is not adequately funded under traditional fee-for-service mechanisms. So when we heard about the statutory goals of CMMI, one thing you heard is that at worst, cost has to be neutral. So CMMI is not set up, for example, to implement something that may double quality, but it adds 1% to cost. That's not the way it's structured. The top priority is we need to do something to get control over costs. We can't pay more to see better quality. And I find it interesting, for example, that if you were to look at the proven benefits versus risks of palliative care for people with serious illness, if that were a drug rather than a service, and it cost $500 a month, everybody with serious illness would be on that medication right now. But because it's seen as a healthcare service, because it's not funded adequately in traditional fee-for-service Medicare, that palliative care has to then prove that it can save money, not just improve quality. Next slide, please. So I want to just look a little bit about how we got here. I want to pick up on a theme I heard from Dr. Lamas, which was that, once things started to settle down, we realized we knew a lot about how to take care of people in critical care before this pandemic. Why have we forgotten to go back to the basics? I heard that from Dr. Hooper too, that, we know some things about building trust and dealing with disparities. So let's just think, what have we learned and what have we been doing to move toward value before this pandemic hit us? We can go back a lot further than this, but I'm going to focus on Medicare. That's not to diminish work that's been done with commercial payers. I particularly like to say that the Center to Advance Palliative Care has done some fantastic work with commercial payers. But we're going to look at Medicare, still the biggest payer for people with serious illness. And I'm going to, you could say the first move toward value was perhaps the hospice benefit. The Medicare hospice benefit was way ahead of its time. It's still a gold standard for end-of-life care, for providing quality, and when used appropriately, it also controls costs. But in 2010, it was the Affordable Care Act that established CMMI, and you heard about their statutory requirements. In 2014, as part of their round 2 of their Healthcare Innovations Awards, the Four Seasons Compassion for Life and Duke were awarded a community-based palliative care demonstration. So there was another move toward looking at palliative care for people with serious illness. In 2015, the macro legislation established a quality payment program for physicians. This is where you have the merit-based incentive payment system, or MIPS, and the alternative then to go into alternative payment models, or APMs. This really accelerated the move toward value. It also created something called the Physician-Focused Payment Model Technical Advisory Committee, which I'm very glad has been shrunk to PTAC, because that's a lot of words. In 2015, CMMI launched the Medicare Care Choices Model, which is really a model of concurrent hospice care. If people had one of 4 diagnoses, cancer, heart disease, lung disease, or AIDS, and they were eligible for hospice but wanted to pursue disease-related treatments, they could actually enroll with a hospice provider who participated in this, and they could, the hospice had to provide everything but the related care. And this model was actually extended from 3 years to 5 years and is wrapping up now. And it was one of the more successful models that have been tested. Next slide, please. In 2018, CMS awarded macro funding to the American Academy of Hospice and Palliative Medicine and partners, the RAND Corporation and the National Coalition for Hospice and Palliative Care, to develop palliative care quality measures to use in the quality payment program. And in 2021, CMS CMMI announced a number of models affecting folks with serious illness, launched the value-based insurance design hospice carve-in option. But we also heard this year that the serious illness population model under Primary Care First and the geographic directing contracting models were placed on hold, and actually heard today that CMMI will not be going forward with the SIP model. We also, of course, heard about the new strategy. Next slide, please. Now, I'd also like to look at what some of the stakeholder organizations have been doing during this same time. In 2015, let me back up for a second. When we look at quality over cost, we've focused primarily on cost. And one reason is that we have limited resources and we're paying a lot for everything. But we've also sometimes focused on cost because it's a little hard sometimes to capture quality. And so in 2015, Measuring What Matters was convened by AAHPM and the Hospice and Palliative Nurses Association to look at what are the best quality measures we have available for quality improvement. They were mostly process measures, and process measures are limited. In fact, when I reported to you that of the 11 high-income nations, the United States is last in outcomes, but first in spending, there's one other category they do well. We're second in processes of care. So we do a lot of care processes. We can check the box, but we don't always see the outcomes. So when we did Measuring What Matters, we did learn that, aside from, with very few exceptions, most of the measures available were process measures, which can be sometimes topped out. In other words, people can develop processes where they're hitting 100%, but are they done well? Do they really drive the outcomes we're looking for? In 2018, PTAC recommended 2 APMs for testing. These were proposed by AAHPM and also by the Coalition to Transform Advanced Care, or CTAC. These models had some similarities. They were both recommended. And in fact, AAHPM and CTAC engaged in joint recommendations to CMMI. And that informed the development of some of these serious illness models, which I'm sad to hear are on hold or not going forward. We'll still need to come up with something for the serious illness population. In 2018, the National Consensus Project published their 4th edition of their clinical practice guidelines for quality palliative care, really calling for care coordination and some basic structures and processes of care we should use for all folks with serious illness. Next, please. In 2019, Amy Kelly and others published a method for identifying the SI population using ICD-10 codes and claims. It's a great place to start for finding that population who needs this intervention and for measuring their quality. In 2021, the Palliative Care Quality Collaborative launched its registry, first unified program and patient-level data registry for our field. And also this year, the Palliative Care Quality Measures Project, that was funded by macro funding, submitted 2 patient-reported experience measures for NQF endorsement. Next slide, please. So where are we now? I want to focus just for a minute on the new quality measures. This Palliative Care Quality Measures Project was a cooperative agreement for $5.5 million awarded by CMS to AAHPM, the RAND Corporation, and the National Coalition for Hospice and Palliative Care. They went through a very rigorous process to home in on 2 patient-reported experience or outcome measures. The percentage of patients with a recent outpatient palliative care visit who report feeling heard and understood by their palliative care provider and team, and the percentage who feel they were getting the help they wanted for their pain. You can see a link at the bottom to where you can learn much more about these measures. These addressed a significant gap. Next slide, please. These are these 2 issues around communication, do you get me? And symptom control, have you got me? Matters to patients and clinicians. This fills a major gap in our measurement of quality. It included, and what I really want to point to, and this really goes with the new CMMI strategy, is in developing these models from the get-go, we really engaged the patient community. We had patients on our technical expert panel. We had a very vigorous public engagement during the comment period. We heard from over 200 stakeholders, mostly very positive comments, but many of them were chronic pain patients or patients with serious illness. And this is currently up in the current cycle for NQF endorsement. Next slide, please. So where do we need to go? And I'm going to just point that we have at the bottom, you can see where you can get some recommendations from the National Coalition for Hospice and Palliative Care. We've submitted these to CMMI. Here's the gist. We need to apply cross-cutting structural and process requirements and quality outcome measures to all payment models that care for people with serious illness. Okay, we need to build on that work to identify the seriously ill population, and we absolutely have to advance healthcare equity. People with serious illness should receive the same high quality care regardless of payment model. I'll wrap up quickly, a couple more slides. Next slide, please. We also have an insufficient specialty level interdisciplinary palliative care workforce to meet our current and growing future needs. That's why we're a big advocate for the Palliative Care and Hospice Education and Training Act, or PACHETA, which would expand training at both the specialist and generalist level. We need to study and leverage telehealth and spend less time driving back and forth when a telehealth visit will work. And we must address the systemic causes of burnout, moral distress, and inequity. It's not enough to tell somebody that's burned out that they should go and do self-care. I do self-care. It looks like doodling. Next page, please. So here's the doodle. That 3-part aim needs to become the 5-part aim. You see a picture of a sign. If you're driving a large truck, if you hit this sign, you will hit that bridge. We have been hitting the sign. We're going to hit the bridge if we don't really make a difference and transform healthcare. Not just better outcomes, better experiences, lower costs, but sustained by thriving clinicians and more equitable care. Next slide, please. So here's me saying, it is what it is. I don't know what the future brings, but whatever surprises the future may hold, we must provide better care to people with serious illness and their families and caregivers. It was important before the pandemic. It's even more important afterwards, where we have learned so much. We have so many more tools now. We're poised now to make a difference. Let's double down. Thank you.
Thank you, Joe. And thank you, Purva. Can you guys, Rick is back. Purva and Joe, can you hit your cameras? Thanks. So Rick, we've heard a lot from both Purva and Joe about what's needed. I heard integration, that we need to integrate palliative care across departments, across payment models. You sat in the hot seat, both in the seat that Purva's occupying and in the seat of a very large health system wanting to do the right thing. What's it going to take? What are some of the challenges that we need to be ready for?
Well, thanks, John, for the opportunity, and thanks to the Academy for the opportunity to be with you. And I just have been blown away by the presentations today, and I'm kind of in awe of the work that everybody has done over this past 2 years now approaching through COVID. So my hat's off to the team, and I feel a little inadequate to be talking to you all in this context, having not been involved. But I will offer some thoughts and look forward to the conversation. First, we're in this 2 years ago, we thought we're in the midst of transforming healthcare. And what we've seen is an incredibly challenged and meeting the challenge healthcare system step up and do incredible work. And even as that has happened, they have continued oftentimes to on this work of transforming healthcare through the various models that we've all talked about. So we're kind of in a time where there's this, question, right? I mean, most immediately before us, is COVID going to be in the rearview mirror in a meaningful way, or is it actually going to be part of our context going forward? I'm not sure what the answer is to that, but I think we have to think about a little bit as we think about healthcare transformation. And so I offer a couple of kind of comments on where we are in this. Things are a little paused from the transformation side, I would say, as Purvis said. I would say we've had it, we haven't had a blow you away success experience with the accountability models like ACOs and bundle payments, but we have seen, I think, success from what in fact has been a limited test. And it's been a limited test because of limited commitment by providers, because there's change is hard. No one totally turns their care model or their business model upside down without a need, a reason, strong reason to do it. And providers have not done it yet because the need is not there. We have not created a forcing function. They've not concluded they must transform. They've been working at it and are continuing to work at it, I would say now. I think we need more forcing functions. We probably need a mandatory ACO path. I think any additional waivers and continuation of the waivers that we've put in place, that have been put in place through COVID, should be thought about as only being granted in the context of providers who are actually accepting accountability for the triple or the quintuple aim, perhaps as Joe just described to us, not in just an ordinary fee-for-service kind of way. We've had an extraordinary period of time where telehealth has, grown incredibly rapidly, and that's great. It should continue, but it should be in a context, I believe, of providers being accountable. I think consistent with the great strategic refresh that Purva talked about and that the team created, and congratulations to you all, Purva, on that. Any activity specific to people with serious illness should be structured to be consistent with those strategic pillars and in the context of accountability, I believe. So I would also say, the community palliative care model is an example of what I would say is a care model as opposed to a payment model. It's a care, fundamentally, we're talking about a way of delivering care to this population of folks now, including folks with COVID. And we know CMI has said they need to curate the portfolio. They need to integrate new models into existing models, et cetera. And I think that's the right thing to do. What I would suggest to think about is how would you go about an integrated test of a model for that provided care for the seriously ill population, as Joe described. And I think about a team-based, community-based care model test that would be testing within the context of ACOs, within the context of accountable care that exists today. What's the best way to actually deliver this care model? Is it delivered best by a focused team that is doing this, or is it delivered more broadly by the care management population-based approach of the ACO? And I'd say at Trinity, we kind of confronted this inadvertently, perhaps, because we had lots of people wanting to do lots of different great things. And I think what we found is that within the ACO, it's difficult to kind of create a carve-out model and adequately resource it. Because the truth is there's a food fight for resources within accountable care today, within the institutions that are operating these ACOs. And so to get a real test of a care model that's specific, like the community-based palliative care approach, I believe CMMI needs to think differently. I think we need to think about actually funding the care model directly, not necessarily as a payment model initially, but as a way of delivering a specific service. So I would suggest, just for thinking about, a model like this and a care model generally, how might we go about it? Well, we might offer it in both ACO and non-ACO contexts to see how that matters. We would provide pretty specific specifications for what the model is. This is not the approach of, hit a number, hit a target cost, and you can do it at whatever way you want. This is about testing a specific care model with elements that would be pretty well, not totally defined up front, but pretty well clarified in terms of what we're expecting. A direct funding of the defined intervention, as opposed to saying, do it within your ACO and it'll come out in the wash and we'll see whether it generates more savings. I would not take that approach. I think doing that, you'll end up with a food fight you'll end up with what we have in ACOs in some ways already, an inadequately funded, a partially funded model that doesn't answer the question, does it work? What we want to test is that we want to test a care model. We want to do it adequately with defined elements so we can say yes or no, this makes a difference. Maybe it does, maybe it doesn't. I don't know. We need a clear definition of success of that model, clearly. I would suggest something like 50% of the participants should be from communities that demonstrate significant healthcare inequities, particularly those with a lower life expectancy or other dramatically different healthcare outcomes. And with regard to evaluation, we're not testing yet the whole issue of payment plan per se. We're testing whether or not this specific model does deliver a set of outcomes that are different when delivered by a dedicated team versus by an overall kind of generalized care management approach. So all of that, I think we can decide after that how to pay for it, whether it's what the payment mechanism might be. The critical point would be, do we know after 2 years or a year or 2 or 3, do we start seeing evidence that this really makes a difference? And the one other thing I'd say, kind of bringing the COVID piece back, is we have to learn faster. You know, we just know, and it's possible to learn faster. It's possible for the health system to move faster. We need to match our evaluation capabilities with the speed with which the system can change. And that's a new challenge that I think that the Innovation Center and CMS as a whole needs to confront. We can't learn in 2 to 5 year cycles. That just is not a way to move the system forward, I think. And we know that people in the healthcare system can innovate much more quickly than we had thought. So I just offer those as some ideas about how to get at this issue of, is there a better way to actually deliver care to this population that can be ultimately be funded in a way that's consistent with meeting all 5 of the objectives that Joe laid out.
So Rick, thanks for those ideas. Zeroing in on the perspective that you're offering those ideas from, as a former CEO of a large health system that wanted to do the right thing, wanted to do more work on this. From that perspective, what problems would this approach of testing the care model and not just the payment model, what problems would that solve? Yeah. To enable the folks who want to do more on this to do more on this from the health system standpoint? Well,
you know our people at Trinity. We had great people who were dedicated on the ACO side. We had great people in the community palliative care side. I honestly don't know what's happened in the last 2 years. Fabulous people, right? But you can't run everything from the CEO office, right? People on the ground are doing real work, and you got to give them the opportunity to run things, right? And so you needed to have an organization that was overall running the pop health stuff, right? And they had lots to do to just run the regular system, right? And so to say, well, we're going to put another system in place, we want you to dedicate these resources, they're going to be paid differently. It created complexity, and ultimately it becomes a resource question. Even within big, $20 billion healthcare systems, at the end of the day, there are people running units, departments, teams that have budgets, right? And so I think what this approach would do would be to eliminate that issue and to say, okay, look, we are going to test something very specific. The dollars are on the table. And I worry that, and I know when I sat in the seat at CMS, we'd say, well, we'll give you objectives, you figure out the best way to do it. Well, that's fine. But, the reality is, if you want to answer a specific question, does a model like this make a difference? You have to kind of commission that model, right? And you have to kind of pay for it to get done, I think. It doesn't need to be a lot. I threw some numbers out. If you did 10,000 lives, which would be a big number, it costs you like $30 million a year. And so over 2 years, it might cost you $70 million. We spent more than that to evaluate some of the models. So I think it's not a giant number, but these are the kinds of, I think, tests you might want to think about. I'm not going to tell Purva and Liz Fowler their jobs. I just throw these out as suggestions, as ways of, thinking about this, coming from having seen how these things play out on the provider side.
Well, Rick, I was hoping we could all work out a deal today on this session. And we know how action-oriented you all are. Joe, let me turn to you. What did you pick up in Rick's ideas there. You put a lot of ideas on the table, but primarily around testing a dedicated care team and carving out funding for that, and that would work with other departments in implementing a model, and then testing that against a totally integrated but approach like an ACO, but without the added care model and dedicated team. What would you pick up on?
Well, so I love the concepts and would absolutely like to explore this further. Let me just kind of point out a couple things. One is that if we were to look back at the first huge innovation was the Medicare hospice benefit. Nothing like it before that. Well, the Medicare hospice benefit included in its conditions of participation things we don't normally consider part of healthcare spending, like you had to have somebody who is doing spiritual assessment and providing spiritual care. That's not a typical part of the healthcare benefit. So, the hospice benefit is successful. It's been tremendously successful. It has its problems, but when it's used properly, it really delivers quality at a good price. But it did things that were not considered part of healthcare. So I'm going to go back and say we have a value problem, right? We spend the most and we have the worst outcomes of these 11 high-income countries. You know what the other ones do? They have universal healthcare coverage and they pay more for social supports. What is part of what happens with people with serious illness is they have burned out caregivers. They have many of the social determinants of health. When we look at the healthcare disparities in serious illness or end-of-life care, those social determinants are really important. And so to your point, Rick, if we're going to test it, we also have to have a basis of comparison that acknowledges that we're doing something that maybe is outside the usual remit of care of traditional medicine. And that's why I think when we are competing just on can we save dollars, it's wrong for several reasons. One is we have an underinvestment to begin with in certain things that we know palliative care, whether it's at a specialist level or at a generalist level, can deliver. And so, yeah, I think these are great ideas. The other reason that comparing on cost alone is just wrong, that's not why palliative care exists. We do not exist to control costs. We exist to give each person with serious illness the best quality of life they can have. Many times that saves money. Sometimes that costs more money. If we don't have a way of getting credit for the quality of life we're delivering, then, we can't live in a world where all that matters is cost, because that's not all that matters to us and it's not all that matters to our patients.
Perfect. Can I turn it to you? What did you pick up on in Rick's comments?
Rick, we're open to any and all of your suggestions. So I was furiously taking notes as you were talking. I think you mentioned the word accountability a few times, and that was sort of where the first objective started, driving towards accountable care for all beneficiaries. And right. I think from our perspective, that means that, we have to create pathways for more providers to be able to engage in value-based payment. I think we have to think about the conditions that's happening in some cases regionally and locally, and take that into consideration. And then I think we have to create that imperative for folks to move forward, even if it's not mandatory. How do we create that imperative that this is where the system is headed? And, how do we really signal that what we want to be able to move towards is either accountable care entities or ways of delivering whole person integrated care that, address that kind of full range of what patients need. You also talked a little bit about, an integrated model, or how we think about serious illness population in the context of, its own model for testing purposes, or, somehow, aligned with an ACO. And, those are things that our teams are kind of actively doing research on and thinking about and talking to experts on. We welcome conversations with folks about what has worked in the ACO world and what hasn't. I think that's a central question for us, that if we are thinking about a more streamlined and harmonized portfolio of models, what does it look like when we know that there are populations that need more intensive and more specific care or different care delivery approaches, and how do we think about opportunities to transform care for them, either in the context of ACOs or not, if it's appropriate. So I think that's a very live question. And then I think both you and Joe sort of commented on getting beyond measuring costs, but thinking about outcomes and impacts. And I think that's why at the end of my remarks, I stopped and talked a little bit about the broad system transformation impacts, because those are the exact things that we need to be able to measure. And those are the things we want to be engaging with stakeholders about on the front end. So, if we are going to test a model on X or Y, what is it that really matters to patients and caregivers? Because then we want to be able to design a model that impacts those, those issues that folks are bringing forward to us. And so that's, I think, one of the things that hopefully a new approach or a fresh approach to stakeholder engagement will help us in terms of conceptualizing what matters on the front end. So it's not just a payment change, but payment changes that are supporting a different kind of care delivery. And then, I think the other thing you said that struck me was that we have to do it faster. And I think from your time at Trinity, you often said to folks, it's just fail fast. Not always easy to do in government, but I will say that that's also why we think it's really key. It sounds small when I say, oh, we want to do more data sharing with researchers, but that's actually one of the reasons why, right? That if we're able to get more data out there, that's not just within the framework of how we have to really do evaluations, which Rick, you're well aware of, but allows us to generate those more dynamic learnings about models and what's working out there and what isn't. And obviously, we also have our learning and diffusion group at CMMI that is doing some really great work, and I think you'll start to see some things from them early next year as well, in terms of really mining some of our models that are winding down, so that we really understand some of those lessons learned that are more qualitative in nature, that aren't going to be captured by simply were there net savings or not. Again, that's our North Star we have to drive towards, but there are a lot of other ways that we can be impacting system transformation more broadly. And then, John, I know there were a couple questions in the chat related to SIP and sort of how we're thinking about serious illness moving forward. I'm happy to answer those.
So let's go there. The timely day for the discussion with the announcement around SIP. I don't know if we should be mourning or celebrating a potential reframing of it in light, especially in light of this conversation around the care model. I think it was more of a payment model than it was a care model. Can you help us understand? We know this population matters. It was all over your refresh document. Can you just give us some sense of the thinking behind deciding not to go forward with SIP and the serious illness population part of primary cares, and how the stakeholder community can be supportive of your thinking about this? Because of course that wasn't the only model that had this population in mind. So
no, I completely understand. And I guess the timing is good in some ways, that there are a lot of folks at this meeting here that are really champions for that model, and for obviously folks with serious illness. And so glad that to be here to kind of answer any questions on a day where I think lots of folks have been waiting to see what happens with SIP. And as many of you heard, CMS is not going to be moving forward with the SIP component of our primary care first model. It's been under review for some time. In general, the agency's been taking a critical look at the Innovation Center's portfolio based on kind of lessons learned. And they came to the conclusion that the risks of implementing the SIP component of PCF as a valid model test are too high. So evaluation is critical and statutorily required step for Innovation Center models to be certified for expansion. And after a lot of review and careful review, the agency determined that the proposed SIP outreach method, which was designed the way that it was to comply with statutory beneficiary privacy protections, would be very unlikely to result in, sufficient beneficiary uptake. And without that sufficient beneficiary uptake, we're not able to evaluate the model. So, moving forward, I think there are some important lessons learned for us there in terms of, beneficiary outreach and model design that I think we need to work through. I think we, as you said in the white paper, and, I think there have been other colleagues that have, attended CTEC events with you, John, and my participation here. I hope signals that we really remain committed and are committed to seeking opportunities for value-based care for this population. We think this is in line and really supports our strategy refresh, offering patient-centered, community-based medical and social supports for all seriously ill individuals is, continues to be an area of focus. And so, that's where you all come in a lot of ways. We really look forward to hearing your feedback. Joe, some of the ideas you shared, Rick, some of the ideas you're sharing about, how can we kind of, take some of the lessons learned from NCCM and other programs. We also have, as you said, John, SIP wasn't the only part of our portfolio, targeted at, providing better care for these beneficiaries. But we have several new, and ongoing initiatives. We've got the direct contracting high needs option. Obviously, I said we have MCCM. There have been some really, and Joe, you referenced the model as well. There's some great lessons learned there that we can build on. So, as we look to kind of move forward, really welcome your feedback and your thoughts about, what are ways that we can kind of bring some of these ideas to the table and move forward together. So thank you.
Thanks, Purva. I know there was a question around Medicare Advantage plans offering palliative care and what the latest numbers are. I saw a report the other day. I think it's 134 as of earlier this year. We're offering that. That was up from 60 the year before, so that may offer another opportunity. Can we do a quick round on equity as we think about that is a new stated goal pillar of CMMI? And I think the team here would have a good perspective on some ideas on how to tackle that and some challenges that may be associated with that. Purva, could I start with you to ask you, as we think about equity, one of the key parts of that, as Dr. Hooper earlier said, is trust. And trust actually is, in her framing, part of a social determinant. Because it affects so much of your health, and the breakdown of trust between many communities and what you call the traditional health care establishment or system. How are you thinking about that, and what role might players outside of the traditional health system, like community-based organizations, under your other pillar, your partnership pillar, what role might they play?
Yeah, so, as I said, our overall goal right here is to increase the number of beneficiaries and accountable care relationships so that they get more integrated and kind of, I guess, person-centered care. So this obviously in some, the thinking that we're doing moving forward on our models, so we're thinking about how this could include support with social determinants of health, greater access, obviously, greater access to care that's in the home and community-based. We have learned a lot from our work in the accountable health communities model about how to support screening and referrals to community-based organizations. We've also learned a lot through our primary care portfolio on how those screening and linkages can happen. We're planning to offer more targeted learning opportunities for our model participants, to be able to advance SDOH issues, to be able to work with community-based organizations, collaborating with community partners to address those social needs. So, I think it's one of the things that we view. So that's something that's kind of happening across our model development. And then in terms of stakeholder engagement, I think that sharing that evidence and those promising practices and how to support those collaborations between providers and community-based organizations. And then not only to create those linkages, but then sustaining them, I think would be, incredibly helpful kind of moving forward. So, forums like this allow us to do that and then ongoing discussions.
Great. Rick, what would you add to that? Earlier, you said that in the test that you were envisioning, at least 50% of the enrollees, I think you said, would be those who have faced health disparities. So that's one idea on the table. Anything else that you would add around health equity that we should be thinking of?
Yeah, I think, I think if we're really, want to talk about healthcare inequities, healthcare as opposed to health resulting from, more than just the healthcare inequities. I think this administration is committed to addressing important social determinants, and I think across the entire administration, and I think that's fabulous. I think in other places we've written about, wasteful money in Medicare Advantage, and I would say I would challenge Medicare Advantage leaders to come to the table and tell Congress they will not oppose changes to Medicare Advantage risk adjustment that would modify to some extent the overpayments going to MA plans, and take that money and put it into social services as they're debating. Literally right now, today, they're not investing in social services because they don't have the pay-fors. And one of the pay-fors that's sitting on the table, Congress can't take, is the overpayments to Medicare Advantage plans. MA leaders have it in their power to go to Congress today and say, we will be supportive of changing the reimbursement, and that would free up literally hundreds of billions of dollars in pay-fors for social determinants. So that's point one. Point two, I think the reality is that we systematically pay providers, particularly hospital systems, extra dollars as a result of historical redlining. And that's not a statement that many people have made, I don't think, but I believe that's true. And to the extent that we pay Medicare rates at the same level across all communities, we are reinforcing that inequity in healthcare resources. And one interesting way of approaching that would be to say, maybe we should think about payment models that actually look at redistributing dollars in recognition of the historical impact of redlining on hospital reimbursements. And added to that, we would address the underpayments on the Medicaid side that systematically create this enormous leveraging effect of much more healthcare dollars, many more healthcare dollars going to well-to-do communities that were the beneficiaries of redlining, and much less money going to the communities that were the victims of redlining.
So we are at time. Joe, any 10 seconds on your thoughts?
Yay. We're talking about social determinants of health, which is a big issue. And I love your point, Rick, about, the baked in systemic racism. So absolutely. Just one more thing to say about that, though. Before you can do anything to provide the social determinants, you have to identify that they're there. And that means we have to start with a comprehensive assessment that looks at people not just as health entities, but as human beings who have social lives, who have practical problems, who have financial issues. So that's the basis of the palliative care assessment, is what we would call comprehensive assessment across all the domains that matter to a patient, so that they have a care plan based on what matters to them. And that means that we're going to have to then be able to rectify the social determinants that are the real reason that they're not getting equitable outcomes. Thank you,
Joe. So to summarize, as Rick put it, change is always hard, and we're going to need a forcing function to get there. And I think the panelists have put a lot of ideas on the table today. So thank you, Rick, Purva, and Joe.
Well, thanks, John, for moderating that great session. And thank you, Purva, Rick, and Joe. And I think to wrap up, I'm going to continue on the theme where you all left off. But I want to first reflect on when our committee started planning this workshop 7 months ago. We really hoped that it would be a retrospective look at the pandemic. And now here we are, of course, with very fresh concerns about the newest variant and the care delivery landscape that is still changing week by week. So we have been adapting and adapting and adapting at breakneck speed since March of 2020. And here's where I want to kind of pull together this theme from the last panel we heard, because I think it's really been implicit in many of the conversations we've had throughout the 3 webinars of this workshop, which is the sense that we will be at a crossroads when we finally feel that this virus is under control. And, we've seen so much innovation during COVID, so many new ways of caring for patients, of partnering across silos, of organizing our care, many of which, if they persisted beyond the pandemic, would represent a really meaningful improvement in the lives of people with serious illness and their families. But we are also tired, and the threat is that when this is over, we regress to the mean. As we've heard from our speakers and our patients, that is simply not good enough. Yes, patients and families are reeling from COVID, but they experienced gaps in care and unnecessary suffering before the pandemic. Yes, our health system is straining under financial burden, but it's not getting the value it could for its dollars. Providers have been stretching for years, really, to align with value-based care goals while having to keep a foot in the fee-for-service canoe. And our workforce is strained to the breaking point, but that need is only going to grow as the number of people living with serious illness grows. And added to these challenges is the core thread that is run through our workshop, and that and really through our national dialogue, and that is the pervasive disparities in healthcare and health that stem from our country's history of racism. And it's hard in the context of this workshop and this pandemic not to make the parallel that that inequity is another public health emergency, and one that needs to be met with the same ingenuity, the same spirit of collaboration, and the same urgency with which we've met COVID-19. And if, as we regroup and rebuild from the pandemic, we allow for that urgency to dissipate in our policy and our care redesign conversations, if we don't, as Dr. Webb Hooper urged us, take advantage of this opportunity, then we will have neglected the foundational principles of palliative care, that each patient's needs are unique and that every patient deserves the best that we have to offer in healthcare. So for all these reasons, I think the message from this workshop is that we must not regress to the mean as we come out of the pandemic, but to avoid that is going to take strong leaders at every level, willing to think in new ways about the role of the health system on behalf of the needs of patients made vulnerable by serious illness or by a history of inequity. We need to continue to systematically scale up what was working before the pandemic, in particular, expanded access to palliative care in all settings, while integrating the best of the palliative care innovations and adaptations from COVID across all care delivery and all care delivery models for patients with serious illness. I think all of us on the line are stakeholders to the project of using this pandemic experience as a catalyst and an opportunity to transform care for patients with serious illness. And I'm really grateful to all of our speakers in this workshop because they've given us concrete strategies for pulling those COVID adaptations into the future of care delivery for patients with serious illness, for leveraging that expertise and the approaches of the palliative care field, and for holding equity as our priority. And those strategies are a call to action. And like my colleague Joe Rotella said in the last panel, there's never been a time more ripe with opportunity. So with that, I'd like to turn it over to Susan for her closing reflections on the workshop.
Thank you, Bryn, for that call to action. Traditional medicine is disease-centric rather than focused on the whole person or physical, emotional, social, and spiritual health. So it's natural that we have responded to COVID similarly, with rapid crisis response, development of new technologies, and a big hope that it will all go away. If our personal health or job has not been touched by COVID, one could easily ignore the total impact of the virus in our community. Yet palliative medicine offers an alternate way to not just cope with uncertainty, but has the expertise to cultivate hope even under severe conditions. Team-based care fosters connection. Clinicians show up for each other. As Dr. Lamas called out, surviving serious illness is not the same as recovery. The benefit of a holistic approach addressing quality of life and supporting families is obvious. So the compelling theme of this workshop for me is that a palliative perspective offers solutions for our entire health system. I don't know if the worst of COVID is behind us. I do know that we have the tools to pursue transformation of our health system through investment in serious illness care and integration of patient priorities, equitable health outcomes, the health of our workforce and community to better meet the real needs of people with and at risk for serious illness. Thank you so much for joining us today. A video of the webinar will be archived online to view and share. Have a great day.